Dr. Vidya, Dr. Archana, we are live. You may start the presentation. Please.
Okay, so we'll go ahead.
Yes, please start your video as well.
Okay,
Dr.
sure.
Vidya and Dr. Archana.
Okay, sir, visible?
Yes. Please go ahead.
Okay. Good afternoon, one and all. Thank you for joining us for the KCIAPM Interactive Slide Seminar for the month of March 2024. We're from Manipal Hospital, Old Airport Road, Bangalore. I now request Dr. Vidya Amen, the head and lead consultant pathologist at our hospital, to address everyone.
Thank you, Dr. Archana. Good afternoon to one and all. I warmly welcome all the postgraduates and the consultants who have joined for this KCPM slide seminar for the month of March 2024. My special thanks to KCIAPM for giving us an opportunity to host this slide seminar, and special thanks to Dr. Aditya to get having this completely organized for us and getting the slides scanned in time. So we have put in a few interesting slides which ranges from benign to malignant. Hopefully all of you have seen it, and especially so the presenting PGs along with your consultants. I'll now hand over the forum to Dr. Archana. She will take over moderating the session completely for today. So I request the PGs to follow the instructions as given by Dr. Aditya. We'll keep it simple. We'll want only the way you have approached the case diagnosis. Just give us a few inputs on your pattern analysis that you have done on the histomorphology along with few differential diagnosis. Thank you.
Okay, now we will go on now with the case discussion. For the first case, we have Dr. Abhishek Bhadra from Vaidehi Medical College. Dr. Abhishek, can you please unmute and share your screen and start off with your presentation?
Yes, ma'am. Can you hear me, ma'am?
Yes, I can hear you. But your screen is not visible.
Is it visible now, ma'am?
Yes. Can you go into the slide share mode? Yes, it's visible now.
Visible,
You
ma'am?
can start. Yes, visible. You can start.
Good afternoon, everyone. I'm Dr. Abhishek Bhadra, first year postgraduate resident from Vaidehi Institute of Medical Sciences and Research Center, Bangalore. And I'll be presenting case 1 of KCIPM slides March 2024. So the history that was given to us, it was a 70-year-old male patient with persistent diarrhea under evaluation, and endoscopy showed terminal ileal erosions. Under scanner 4X, mucosal ulcerations were noted as they have been showed by the blocked black arrows in the picture, along with inflammation in the lamina propria. So we can see some lymphoid follicles in the lamina propria. Again, in low power, we can appreciate the mucosal ulcerations and the inflammation in the lamina propria. Under low power, as denoted by the blocked black arrows, H&E stained sections of ileum shows subepithelial extracellular homogeneous patchy eosinophilic material, possibly resembling amyloid or collagenous deposits. So under high power, we see these subepithelial eosinophilic deposits, and also under high power, we see this eosinophilic patchy deposits in the perivascular areas as well, as denoted by the black arrows. So again, one more slide with the black arrows showing two vessels with eosinophilic patchy deposits around them, mostly resembling amyloid. Under high power, the lamina propria also shows inflammatory cells, mainly comprising of plasma cells, lymphocytes, and few eosinophils. And the submucosa shows a normal appearing intestinal glands, and mucus muscularis propria was also unremarkable. Now, I thought that a few sections also showed thin-walled broad hyphae with septation, As showed by the black arrow, you can see the thin wall and the septation in the fungus, resembling mostly a fungal organism. So my differential diagnosis, amyloidosis of small intestine. Second differential diagnosis, collagenous ileitis. Third diagnosis, intestinal fungal infection, which has to be confirmed using special stains like GMS and VAS. So points favoring are the subepithelial and perivascular extracellular homogeneous patchy eosinophilic amyloid deposits, along with the clinical history of persistent diarrhea and the endoscopic findings of terminal ileal erosions. Thank you.
Thank you for that presentation. So we'll go ahead with the discussion. So the history that was hello, am I audible?
Yes, ma'am.
Yeah, okay. So the history that was provided was a 70-year-old male who presented with terminal ileal erosions. These were the responses that we received. Giardiasis, IBD, mucor/fungal etiology, amyloidosis, collagenous ileitis, and celiac disease. So like you showed, microscopy 10x, it shows these ileal mucosal fragments. There are some areas showing some erosion. The crypt architecture is maintained and there is no cryptitis. Right, the lamina propria shows a moderate lymphocytic infiltrate, and we can also see these extracellular material, eosinophilic extracellular material. On higher power, this material is also seen within the walls of the blood vessels that is seen in the submucosa, and this extracellular deposition in the submucosa. So the key microscopic findings here were this extracellular material deposition and this moderate lymphocytic infiltrate. The crypts are normal. No parasites or organisms were visualized. So what we need to do next is we needed to do special stains. So on special stain, our past stain was negative. So no fungal organisms were identified. And we did a Mason trichrome stain also, and it was not highlighted. So it wasn't collagen either. So next we went ahead and did a Congo red stain. This is the Congo red image under light microscopy. And under polarized microscopy, we see that there is this apple green bifringence in the same areas that showed the deposition. And here the vessels are highlighted by the same. We also received a renal biopsy for the same patient the next day. A brief history that was provided was 70-year-old male, a known case of hypertension, presenting with adult onset nephrotic syndrome and renal dysfunction. So these are some images from the renal biopsy. So amyloid deposition was seen in the mesangium, the basement membrane, and also the wall, vessel walls. And Congo red stain, again, it was positive and it showed this green birefringence. So these were few DDs that you shared. For fungal etiology, the past stain was negative. For collagenous ileitis, again, the empty stain, it didn't take up stain, so it wasn't collagen. And there wasn't too much surface injury or intraepithelial lymphocytes. So the final diagnosis is amyloidosis in a patient with systemic amyloidosis. So I'll just briefly discuss about amyloidosis. They're a rare and heterogeneous group of disorders, and it occurs due to deposition of these abnormally folded proteins. And these proteins, they aggregate in various organs and leads to progressive organ damage. So the current classification that is accepted is based on the type of amyloid. So A stands for amyloid, and what follows is the abbreviation for the protein. So AL is the most common type, and that is aggregation of immunoglobulin light chain proteins. So this is also called primary amyloidosis, where you have light chains accumulating, that is lambda and kappa. AA amyloid associated, this is secondary amyloidosis, and this is commonly seen in conditions where there is chronic infection, granulomatous conditions, And then you have the A beta type, which is seen in Alzheimer's disease. So this is just an depiction. It shows the pathogenesis. So the accumulation occurs either because there's an increased amount of production and the protein is normal, or there is an abnormal amount of protein. So certain special stains, we've already done Congo red. Thioflavin can also be done, and these bind to the beta-pleated sheet of amyloid. Also, IHC can be done. There are antibodies that are directed against all these different proteins, but IHC may not be available everywhere. So a case of amyloidosis has to be worked up. Protein electrophoresis has to be done to assess the immunoglobulin production. A urine protein electrophoresis has to be done to assess for clonal light chain production. Also serum free light chain kappa to lambda ratio. And we need to work up to see if there's any systemic amyloidosis. So in the kidneys, you can do a urine albumin creatinine ratio. In the liver, alkaline phosphatase levels can be checked. And for the heart, all these tests can be done. So this has to be correlated with a renal biopsy and other clinical and biochemistry investigations and hematology. Thank you. Does anyone have any questions? Okay. Thank you.
Thank you, Dr. Varsha. Since there are no questions for the first case, let's move on to the second case. The second case will be presented by Dr. Nivedita JD from Sri Atal Bihari Vajpayee Medical College, Bangalore. Dr. Nivedita, you can unmute yourself and start sharing your screen, please.
Good afternoon, ma'am. Am I audible?
Yes, you're audible.
Is the screen visible, ma'am?
It's taking, yeah, can you go to slideshow mode?
Yes, ma'am. It's in slideshow mode.
No, are you sharing your entire screen?
Yeah.
It's not. Can you go to the next slides? It's not in slideshow mode. Can you do one thing? Can you stop sharing and share the entire screen again?
Yes, yes.
Dr. Nivedita, this time share your entire screen. Click on screen. Share and click on screen.
Is it visible?
No, Dr. Nivedita.
No, Dr. Nivedita,
Yes.
wait, just follow as my instructions. Click on share and click
Yes,
on
sir.
screen, not the PowerPoint.
Okay.
Now open your PowerPoint.
Now is it visible, sir?
No, open your PowerPoint. Click on share button, screen, and then click share. Okay, now open your PowerPoint. Now put it on slideshow.
Is it visible now, sir?
Yes, go ahead.
Good afternoon to one and all present here. I am Dr. Nivedita, first year postgraduate from Sri Atal Bihari Vajpayee Medical College and Research Institute. The slide which we received was of a 23-year-old female with a lesion on the back with a clinical diagnosis of Poiré abscess. On a low scanner view, we could see 4 tissue fragments which composed of skin with epidermis and dermis. The epidermis was unremarkable, and the superficial and deep dermis showed diffuse inflammatory infiltrate, which consists of lymphoplasmacytic infiltrate along with
Dr.
histiocytic
Nivedita,
hydrate.
1 second. I'm not able to see your slides. Aditya sir, are you able to see her slides?
Dr. Nivedita, what side are you seeing? Dr. Archana will do one thing. We'll move to the next case. We'll come back to her later.
Okay, sir, done. Okay. So we'll move on to the next case. That's case number 3, which will be presented by Dr. Mercy Hadassah from Mysore Medical College, Mysore. Dr. Mercy, can you share your screen and unmute yourself, please?
Dr. Mercy, unmute first.
Good afternoon to everyone. Am I audible, sir?
Yes. Please start your presentation.
I'm Dr. B. Mercy Hadassah. I'm the first year postgraduate from Mysore Medical College and Research Institution. I thank KCIAPM for giving this opportunity to me. Here's the history. A 40-year-old male, colonoscopy showed large pedunculated polyp at descending colon and multiple small sessile polyps throughout the colon. Query polyposis syndrome. Here the micrograph picture on scanner view shows a polypoidal lesion lined by columnar epithelium and the stalk. On low power view, we are seeing the mucosal ulceration. That is, here we are seeing the discontinuation of lining epithelium. Here we are seeing the conserved crypt architecture with variable elongation. Here this crypt is elongated till the basement membrane. Here it got stuck only the upper 1/3 of the mucosa. And we are seeing the varying sizes of the glands. On high power view, here we are seeing the low-grade dysplastic changes, that is pseudostratification, hyperchromatic, and elongation of nucleus. And the underlying stroma are infiltrated by chronic inflammatory cells and also the congested blood vessels. Here, the polypoidal lesion with a stalk without the invasive glands. So based on the features that I have discussed, those are the increased number of glands, conserved crypt architecture with variable elongation, and the low-grade dysplastic changes like pseudostratification, hyperchromatic, and elongated nucleus. The features are suggestive of adenomatous polyp. Adenomatous polyp is a neoplastic polyp. It is a precursor to the invasive adenocarcinoma due to the defect or mutation of KRAS, TP53, and APC. Mutation of APC gene leads to the accumulation of beta-catenin and dysregulate the WNT signaling pathway. Activation of KRAS leads to the decreased apoptosis, neoplastic cell proliferation, and survival. The IHC markers which are used are P53, BCL2, and microsatellite instability. So my differential diagnosis were, though the gross features of the hyperplastic polyp and adenomatous polyp are similar, that is multiple small and sessile, on low power view, the epithelium is serrated and sawtooth appearance of glands are seen. And on high power view, the epithelium showing gland basally placed nuclei without the dysplastic changes. Hence, we can rule out this hyperplastic polyp. So the second one is inflammatory polyp. Here the nuclei can become elongated like a tubular adenoma, but nuclei are typically vesicular with round borders. And here we are seeing the crypt architecture distortion. Then the tubulovillous adenoma. Here the surface epithelium has greater than 25% of the villus architecture and high-grade dysplasia with prominent nuclear stratification. Thank you.
Good afternoon, everyone. Myself, Dr. Nazma. I'm from Manipal Hospital. Before going to the case discussion, I have a few questions for Mercy. Mercy, can you hear me?
Yeah, ma'am.
Yeah. So your differentials were adenomatous polyp slash hyperplastic polyp. So before going for that, I want you to ask, like, if you have did you look at the stroma of the polyp before going for the
Yeah, ma'am.
diagnosis? Okay.
Yeah,
Did
ma'am.
it look fine? So fine. And I wanted to ask you, did you see any invasive glands?
No, ma'am.
I heard you mentioned that there were some glands, like invasive glands. Did you see them?
Without invasive glands, I mentioned.
Yes. Okay. Okay. Thank you. So I was just confused. Thank you. So I'll be starting with my presentation. Case 3, history, as everyone knows, it's a 40-year male presented with multiple polyps. The largest polyp was seen in the descending colon and it was pedunculated, and there were many small sessile polyps throughout the colon. So they were suspecting polyposis syndrome. So the differential diagnosis provided by the PGs were hyperplastic polyp, inflammatory polyp, and tuberculous polyp, adenoma. Sorry, and the different responses from the institutions received had multiple DDs, and I have grouped them into few. Majority of them have called it as focal neuromatosis with hyperplastic polyp. Uh, Basically, they have called it as ganglioneuromatosis with either associated hyperplastic polyp or Peutz-Jeghers polyp or juvenile polyposis syndrome. And the lesser sent DDs were adenomatous polyposis coli, tubulovillous adenoma with low-grade dysplasia, attenuated FAB, and Cronkite Canada syndrome. So let's get back to the slides. Uh, at lower power, you can see the polypoidal configuration, and as rightly mentioned by Mercy, there is a stalk. So here, what you can see is at this magnification, you can see that there are some few, cystically dilated Krebs glands. Coming to the high power, there was a focal mucosal ulceration, as she pointed out, but the entire mucosa was intact. Coming to the glands and the lining, there was no like significant dysplasia or atypia. To call the cells to be dysplastic, there should be a loss of polarity, hyperchromasia, and irregular nuclear membrane. That at least that has to be there to call it as a dysplasia, which will qualify to either adenoma or tubulovillous adenoma, anywhere it can be. So coming to the slide, and at this magnification, apart from seeing some cystically dilated glands and normal lining epithelium, yeah, excuse me.
Dr. Mercy, you'll need to tell me if you can see the slides or no, okay?
Okay, ma'am.
Are you able to see the slides
No, ma'am.
now? Dr. Mercy, can you see it now?
No, ma'am.
We've done the same thing.
Stop sharing completely. Log out and log in.
Now, can you see? Dr. Mercy, can you just reply to me if you can see or no? Because I need some feedback.
I'm not visible.
Not
It
visible?
is not visible.
Okay, give me 1 second. Come there. Just give us 2 minutes.
She replied,
Are you online?
Yeah, ma'am.
Okay. I'm trying to share again. Just check, please.
Okay, ma'am.
Is it
Yeah,
visible?
Yes, Dr. Archana, it's visible.
Okay, great. Okay. Mercy, now it's visible, right? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay. So as I already discussed, a polyp which has a normal lining and few cystically dilated glands. Coming to the higher part, here we can see some small proliferating benign glands and cystic glands, and we can see the muscularis mucosae. So the lining and the crypt glands almost look fine, but what is not okay is the lamina propria. Usually the lamina propria is less busy. It is not as busy as we are seeing it right now. So here you can see that there are a few scattered large cells, and also we can see some spindle shaped cells, right? There are definitely some inflammatory cells, but our point of interest is the cells and the stroma. Going to the higher part, these cells are more clear, and you can make out that they are in small nests, and these individual cells are large and shows eccentrically placed nuclei with vesicular chromatin and prominent nucleoli. And also the background shows some fibrillary matrix. To point you out, as you mentioned that there was a dysplasia. To be clear, there was no dysplasia in this case, and not at a single focus, there was a dysplasia. Okay. These are the cells again. So, Mercy, can you hear me now?
Yeah, ma'am.
So, didn't you see these cells in the primary, like when you screened the slides? Maybe you have missed it, right?
Yeah, ma'am.
Yeah. Now you can tell me, like, it's okay. You tell me what are these cells like? How do they look usually? Eccentrically placed and abundant cytoplasm and neurofibrillary background. So, what do you think?
Peripheral clearing.
Hmm. Okay, there is a peripheral clearing. Okay. So,
Arranged in nest.
can you name some cells which have eccentrically placed nuclei?
Plasma cells, ma'am.
Yeah, very good. But to call this as plasma cells, they are quite larger than plasma cells. So you can see some lymphocytes here. There is actually a plasma cell here, and these cells are larger than. So any other thing? Any other cell? Okay, let's move on to this. So these cells are nothing but the ganglion cells, and the matrix which is behind is called neurofibrillary matrix. So after seeing these cells, we went up and we did IHC, and these large cells were stained positive for S100 and calretinin. And also the neurofibrillary matrix in the background took up S100, so which confirms that it has a neural origin. Now, can you tell me any cells you think of which is taking S100 and calretinin positive? So these are ganglion cells. Okay, just a second.
So, okay. So the final diagnosis we gave was a ganglioneuromatous polyp, because yeah, at initial stages, like when you see at the lower part, it might look like a hyperplastic polyp, or it might even look like a juvenile polyp. But what matters is what are the cells, and the lamina propria and stroma decides under which category the polyp falls. Okay. So coming to the discussion, these ganglioneuromas are slow-growing hematomatous tumors that are rarely found in colon, and they originate from the undifferentiated neural crest cells. So there are three subtypes of ganglioneuromas. They are called as either polypoid ganglioneuromas or ganglioneuromatous polyposis and diffuse ganglioneuromatosis. The most common type is polypoid ganglioneuroma, which is either a pedunculated or sessile. They are usually small, and they are presented with a single polyp. And these polyps arise from the mucosa and submucosa. Ganglioneuromas can be associated with genetic disorders depending on their subtype. Single lesions such as polypoid ganglioneuroma are usually an isolated finding. They are not associated with any genetic syndrome. So as I told, there are three types. The first one, the polypoid ganglioneuroma, which presents like a single polyp, has no genetic association. Whereas the ganglioneuromatous polyposis can have associated anatomic findings like several skin tags or cutaneous lipomas that can be present either on the face or on the extremities. Coming to the diffuse ganglioneuromatosis, it can be isolated, but they are typically associated with syndromes like MAN2B or neurofibromatosis. They can also be associated with non-familial adenomatous polyposis, juvenile polyposis, Cowden's syndrome or disease, or Ruvalcaba-Myers-Smith syndrome. Ganglioneuromas, grossly, it can be either sessile or pedunculated, resembling juvenile polyps, or it can even resemble tubular adenoma or hyperplastic polyps. But microscopically, the most common pattern is a juvenile polyp with distorted crypts and cystic glands at lower magnification. As we go for the higher magnification, what you can see is collections of spindle cells in a fibrillary matrix and irregular groups and nests of ganglion cells within the lamina propria. So, a few insights into the ganglioneuromatous polyposis. They are indistinguishable from solitary ganglioneuromas, but they show variability in the supportive cells. They show villiform mucosal projections containing clusters of ganglion cells with no apparent neural component. Whereas diffuse ganglioneuromatosis, which is usually associated with syndromes, show transmural proliferation of ganglioneuromatous tissue involving the entire plexus. The case which we gave it to you was a ganglioneuromatous polyp. Here, the neural tissue and the ganglion cells were limited to the lamina propria. But in diffuse ganglioneuromatosis, you can see the proliferation of ganglioneuromatous component in in all the layers, including submucosa and the muscularis propria. Shaped mesenchymal cells, which include Schwann cells, lacking atypia or mitotic figures, and ganglion cells present within the expanded region. It may be either singly scattered or they may be abundant. So these cells take S100 and NSE. So
Dr.
differential
Najma,
diagnosis.
Are you sharing your PPT? Are you showing some slides, or
I'm showing my
no?
slides.
Just give me a
Okay.
second.
Yes, yes. Is the presentation visible?
Yes, yes.
So the close differentials are ganglioneuromatosis, perineuroma, and mucosal Schwann cell hematoma. In mucosal Schwann cell hematoma, you will not find any ganglion cells. Ganglioneuromatosis and perineuroma. Perineuroma will stain negative for S100. Okay, these are my references. Thank you.
Thank you, Dr. Nazma. Let's move on to the next case. That's case number 4, which will be presented by Dr. Shivangi, SDM College of Medical Sciences, Dharwad. Dr. Shivangi, can you please
Yes,
unmute
ma'am.
yourself and share your screen, please?
Is it visible, ma'am?
Yes, Dr. Shivangi, please go ahead.
Good afternoon, everyone. I'm Shivangi from SDM College of Medical Science and Hospital, Dharwad. I'll be presenting the 4th case for today. We had received one slide of HND, and the history given was 13 years old female, and the site of biopsy was resected pelvic mass. Here is a microphotography under the scanner view showing ill-formed nodules. On a low power, here is a vague nodular pattern infiltrated by the inflammatory cells. On higher magnifications of the nodules and the other areas, showing cells, large round cells having vesicular chromatin and prominent nucleoli, surrounded by abundant eosinophilic cytoplasm having distinct borders. And focal areas showing cells arranged in intersecting bundles and fascicles. Here is a microphotography. The similar cells were seen all over the slide. These are cells having extracellular matrix, having collagen lobules, mainly seen in the gist. Here is a microphotography showing dense inflammatory infiltrate comprising of predominantly plasma cells, lymphocytes, and occasional neutrophils. Focal areas showing spindly cells arranged in fascicles. Here is a microphotography showing cells having glassy intracytoplasmic inclusions and peripherally placed nucleus having vesicular chromatin and prominent nucleoli resembling the rhabdoid cells. And few areas shows cystic degeneration. There was no atypical mitotic figures, necrosis, or hemorrhage seen in the slide. Based on all the histomorphological features, here are my DDs. First is extra gastrointestinal stromal tumor that is of epithelioid type because it has mainly sphenoid fibers and epithelioid morphology. The other DDs are inflammatory myofibroblastic tumor, epithelioid type, epithelioid sarcoma, epithelioid leiomyoma, and pecoma and rhabdomyoma. Continuing with the discussion of DDs, first is gist of epithelioid type. The common site is in GIT stomach. The other in extra gastrointestinal tract, it is omentum, mesentery, and pelvis. Epithelioid cell tumor constitutes 20% of gist. Here the cells are mildly pleomorphic, arranged in sheets and in nested pattern, having abundant eosinophilic cytoplasm. Next is inflammatory myofibroblastic tumor seen both in children and in adults, most common site being the abdominal soft tissue. On microscopy of epithelioid subtype, there is plump epithelioid cells with vesicular chromatin, prominent nucleoli, eosinophilic cytoplasm admixed with neutrophils in other inflammatory cells in myxoid background. Next is rhabdomyoma. This can be seen both in adults and in children. On microscopy, the cells are large, round, and tightly packed and separated by thin fibrous septa. Finely granular cytoplasm, vesicular chromatin, and prominent nucleoli are seen. On further investigations, immunohistochemistry is helpful in differentiating all the epithelioid tumors. First, we want to rule out the gist. For that, if the CD1111 and DOG1 is positive, it favors towards the gist that is of epithelioid type. And next is succinate dehydrogenase deficient type of GIST. If it shows negativity in SDH, if it shows negativity in SDHB marker, then it rules out the succinate dehydrogenase deficient GIST, which is most commonly seen in the pediatric age, and it has epithelioid morphology. To rule out other epithelioid tumors, Desmin, ALK, and myogenin is helpful. First, if Desmin, ALK, and myogenin is negative, it rules out epithelioid sarcoma, which is positive for CK8, CK19, and 34. Next, if Desmin is positive, ALK and myogenin is negative, it points towards epithelioid leiomyoma and pecoma. HMB45 is helpful to rule out epithelioid leiomyoma. Next, if Desmin and ALK both are positive, it favors towards epithelioid type of inflammatory myofibroblastic tumor. Next, if Desmin and myogenin are positive, it favors towards rhabdomyoma. Thank you.
Dr. Shivangi, are you able to see my PPT?
Yes, ma'am.
Okay. You just need to give me a feedback if it's not visible, okay?
Yes, ma'am.
Good afternoon, everyone. Dr. Shivangi, that was an excellent presentation. So I'm Dr.
Thank you so
Archana, consultant pathologist at Manipal Hospital, Bangalore. So we'll go to this case number 4. So this is a 13-year-old girl who presented to the OPD with 15 days history of pain, abdomen, and vomiting. On examination, her vitals were stable and per abdomen was soft and non-tender. Ultrasound abdomen, she had an ultrasound abdomen which was done at her hometown, which showed a pelvic mass displacing the uterus, measuring about 10 into 8 into 6 centimeter. She came to our hospital for further treatment. So these were the list of differentials that I have got. We'll be going through each one of them in detail. So CT was done at a hospital which showed a mass in the pelvis. I hope you can see it. Can you see it, Dr. Shivangi?
Yes, ma'am.
Yeah, this is a pelvic mass that you can see. It was measuring about 10 into 8 into 6 centimeter, and it had heterogeneous areas. There were some areas of cystic change, there were some necrotic areas, etc. And she also had multiple deposits in the mesentery. This is the bowel loops that you can see here, and she had multiple mesenteric deposits. And on CT scan, they what they told us is they couldn't visualize the left ovary separately, so they have called this a neoplasm originating from the left, probably originating from the left ovary. So further tumor markers were done, which were within normal limits, and after then the diagnostic laparoscopy was done. I'll just show you a video at this point. Yeah. This is a diagnostic laparoscopy that was done. I'll just show you the relevant areas. Yeah. Can you, yeah, these are the bowel loops. This is a tumor that you can see. Can you see the tumor?
Yes, ma'am.
Yeah. Yeah. This is a tumor. This is a right ovary that you can see here. This structure here is a uterus. This again is part of the tumor. These are the bowel loops. Yeah, this is a tumor that you can see. This is a left ovary.
Yes, ma'am.
And there are multiple peritoneal seedings. Yeah, this is a tumor. Is it visible?
Yes, ma'am.
Yeah. And this child also had some nodules on the liver. I'll show you those nodules. Yeah. Can you see this whitish areas?
Yes, ma'am.
Yeah. So there was some nodules in the liver as well. So this is again the image of the same. This is a tumor. this is a tumor. This is the uterus, and the tumor is pushing the uterus anteriorly. And this is the right ovary, and this is a left ovary that you can make out here. This is a uterus, left ovary. This is a mass. So biopsy was done, and the histopath sections, you have already described the slides beautifully. So I'll just go through them again. So what we saw are sheets of these epithelioid cells. And like you rightly pointed out, a few of these had a rhabdoid morphology. They had a epithelioid morphology, round vesicular chromatin, prominent nucleoli, and abundant eosinophilic glassy cytoplasm. And you can see there is a lot of sprinkling of lymphocytes and plasma cells, as you have mentioned in your description. There were also some extracellular eosinophilic matrix material that we could make out in these on histopath. There was another area which showed infarction necrosis. And this is again another higher part of the same tumor. Here you can see the tumor has an epithelioid morphology. It has a round vesicular chromatin, prominent nucleoli, and abundant eosinophilic cytoplasm. There are lymphocytes, plasma cells, as you have rightly mentioned. And there are some extracellular eosinophilic matrix material that you can see. And as you can make out in this image, there is almost no mitotic activity at all. And this is another image. Do you want to guess what this is? Dr. Shivangi?
Yes, ma'am.
What do you think this compressed structure is? Okay, this is a mesothelial lining. Okay, the mesothelial lining. This is a mesothelial lining, and it was seen throughout the tumor like a compressed slit-like spaces. So if you see this image, do you want to, do you have any other differentials? If this was, say, a lady of childbearing age group, or in an endometrial curettings, will you have any other differential on this? What does these cells resemble? Sorry? Okay, I'll come back to it later. Sorry? Okay, I'll come back to it later, Dr. Shivangi. So these were the responses that I received. The epithelioid type of GIST, inflammatory myofibroblastic tumor, rhabdomyoma, epithelioid sarcoma, pecoma, malignant melanoma, mixed germ cell tumor, extraskeletal osteosarcoma with rhabdoid differentiation, granulosa cell tumor ovary, calcifying fibrous tumor, area stellar reaction, decidual change, adrenocortical carcinoma, dendritic reticulum cell sarcoma, rhabdomyosarcoma, and malignant rhabdoid tumor. So an exhaustive list and very good differentials, because even our differentials were more or less the same as you guys have given. So excellent differentials. So we'll go to each one of these differentials. So epithelioid GIST is a very good differential, Dr. Shivangi. So we have done CD117 in this case, and it came out to be negative. We have not done DOG1. This is ALK1, IHC. ALK IHC was negative. This doesn't completely rule out an inflammatory myofibroblastic tumor, because there is a subset of inflammatory myofibroblastic tumor that can be ALK negative. However, the morphology did not favor an inflammatory myofibroblastic tumor here, even though there was some lymphocyte and plasma cell sprinkling that was seen throughout the tumor. So ALK is negative. Then we did Desmin. Unfortunately, I don't have the images of Desmin, but Desmin was patchy positive, and we did MyoD1 in this case. MyoD1 was completely negative. So that rules out rhabdomyoma and rhabdomyosarcomas for us. And your next differential was an epithelioid sarcoma. So we have done CD34 and INI1 for it. CD34 is highlighting the blood vessels. Can you see the blood vessels being highlighted?
Yes, ma'am.
Yeah. So, but all the neoplastic cells are negative. So none of the neoplastic cells are showing CD34 positivity. And INI1 is retained. Okay, so all the neoplastic cells are showing retained INI1 positivity. There is no loss of INI1 in this case. Hence, we rule out an epithelioid sarcoma. Then your next differential was maybe not yours. I think somebody has given us a differential of PCOMA as well. We did do a PCOMA marker HMB45, which was negative. And we also had ruled out melanoma in this case because S100 and SOX10, which are melanoma markers for melanoma, they were all negative. These two are markers for nerve sheath tumors as well. Then, considering the age of the child, we did a pan GCT marker. We did a SAL4, which came out to be negative in this case, hence ruling out a germ cell tumor. And we also had a differential of osteosarcoma with rhabdoid differentiation, as somebody has rightly pointed out. There are a few case report which mentions extraskeletal osteosarcoma in the abdomen cavity in the younger age group, which has a rhabdoid morphology. So we did consider that differential also, because this case also had some extracellular eosinophilic matrix material. We didn't know what it was exactly. So we did SAT-B2. SAT-B2 was negative. However, we know that SAT-B2 is not a very specific marker for osteosarcoma. There are a lot of neoplasms that show SAT-B2 positivity. Can you name few, Dr. Shivangi? Hello? Hello, can you hear me, Dr. Shivangi? Hello, am I audible?
Yes, ma'am.
Yeah, so can you name some one tumor which will be SAT-B2 positive other than osteo?
Adenocarcinoma.
Yeah, right. Adenocarcinoma where, Dr. Shivangi?
Small intestine.
Yeah, all your colorectal adenocarcinomas will be SAT-B2 positive, and also they'll be positive in osteosarcomas. They can also be positive in well-differentiated some neuroendocrine tumors, your Merkel cell carcinoma. They all can show SAT-B2 positivity. Okay, so it's not a very specific markers, but when used in the right context, in the right clinical context, it is very helpful. So we also had got the differential of a follicular dendritic cell sarcoma. So we have done CD23 and CD21, both of which were negative. Considering the age of the child, we did CD99 and NKX 2.2, which are markers for Ewing sarcoma, both of which were negative. So CD99 is not a very specific marker. There are a lot of tumors which show CD99 positivity. However, NKX 2.2 is, as of now, we know that it is more or less a very specific marker for Ewing sarcoma. So in the first panel of markers, the only IHC marker that came positive was a pan-CK. So pan-CK was diffuse strong positive. So Dr. Shivangi, what are the tumors that will show CK positivity?
Ma'am, all the epithelioid tumors.
Okay. Can you give me a few examples? Okay, you meant carcinomas?
Yes, ma'am.
Yeah. What other tumors can show CK positivity? So this case with pan-CK positivity, do you think it's a carcinoma? Or do we have to rule out other differentials as well? Okay. So pan-CK positivity doesn't mean a carcinoma in all the cases. It can be positive in carcinomas. It can be positive in some sarcomas as well, such as epithelioid sarcoma, synovial sarcoma, angiosarcoma, your leiomyosarcomas can all be positive for cytokeratin. They're also positive in mesotheliomas and rhabdoid tumors. So in our case, we have ruled out in our case, we have ruled out an epithelioid sarcoma because CD34 is negative and INI1 is retained. Angiosarcoma is ruled out again because CD34 is negative in this case. And LMS is again ruled out based on the immunohistochemical markers, and rhabdoid tumor is also ruled out because INI1 is retained. So now we are left with carcinoma and mesothelioma. Okay, so from this point, we'll do markers and also synovial sarcoma. Yes. So these are the three differentials that we are left with. And this is Ki67. This was not very high. It was around 8 to 10 percentage. So with CK positivity, we and the history of hepatic nodule and considering the age of the child, we also wanted to rule out a neoplasm originating from the liver. We did HEPAR and AFP. Both came out to be negative. This AFP is a very non-specific background staining. And CK7 was a IHC marker that we did later, which came out to be diffuse strong positive. TLE1 is a marker for synovial sarcoma. It was negative in this case. However, let me point out, TLE1 is not a very specific marker for synovial sarcoma. There are a lot of differential diagnosis, a lot of tumors show TLE1 positivity. So again, this is another marker which we should use very cautiously in the right clinical setting and consider it only if it is very diffuse, strong, positive in the neoplastic cells. So we have ruled out a synovial sarcoma in this case. So at this point, we went back and got a clinical review done. We requested our clinical colleagues to review the CT images and also the diagnostic laparoscopy videos. So a few inputs that we got was there was no organ attachment at all. Whatever tumor mass that was seen was only in the peritoneal linings. Both the ovaries were separate. There was no attachment to the uterus. The liver nodule that was visualized was only a surface nodule. There was no parenchymal involvement per se. And there was no increase in tumor markers, and there is no history of exposure to asbestosis. We asked particularly for these history, and this is what we got. So considering these clinical inputs, we went ahead and did a battery of markers, which included CK7, which showed diffuse strong positivity. WT1, though not very strong, but showed moderate nuclear positivity in the neoplastic cells. D240 was not very helpful in our case. Very occasional cells showed positivity. However, majority of the neoplastic cells were D240 negative. CK5/6 highlighted a few of the neoplastic cells. However, calretinin showed diffuse strong positivity, nuclear and cytoplasmic positivity in the neoplastic cells, and Pax8 was also moderately positive. So based on these IHC markers, we gave out a diagnosis of epithelioid malignant mesothelioma, Deciduoid variant. So this was our final diagnosis in this case. So deciduoid mesothelioma is a term used for an uncommon subtype of epithelioid mesothelioma that is characterized by the presence of cytomorphological features resembling decidua or decidualized tissue. So in 1985, Tallerman et al. Reported the first case of this mesothelioma variant, which arose in peritoneum of a 13-year-old girl. This patient died 8 months after diagnosis. In 1994, Professor Nascimento reported 2 additional cases of similar type of mesothelioma arising in peritoneum of women 23 and 24 years of age, and he coined the term deciduoid mesothelioma. Clinically, it is considered to be a very aggressive tumor and occur in the peritoneum of adolescent girls or young women who had no history of asbestos exposure. However, further studies have shown that this is not restricted to the peritoneum of young women and not restricted. However, they can also be seen in pleura of older men or women who have history of asbestos exposure. And of the 64 cases of deciduoid mesothelioma that is reported in literature, 34 occurred in males who range in the age group of 13 to 78 years and 30 in females. And 39 cases of these tumor originated in the pleura, 22 in the peritoneum, and only 27 patients had history of asbestos exposure. And on on histomorphology, these tumors have the characteristic appearance as we have seen in our case. They are large polygonal cells, round ovoid cells with well-defined cell borders, abundant eosinophilic glassy cytoplasm, round vesicular nuclei with prominent nucleoli, and mitotic activity is said to be variable. You may not get even one mitotic figure, or there may be very high mitotic activity with presence of atypical mitosis, and some rhabdoid changes, mucinous change, and myxoid stroma is known to occur in this tumor. So the IHC panel in mesothelioma, these are the common IHC markers that we use in mesothelioma: pancytokeratin, WT1, calretinin, CK5/6, D240, GATA3, and Paxate. However, as you can see in this table, the percentage of tumors that show positivity is very variable. Hence, and none of these markers are actually very sensitive or specific for mesothelioma. Hence, whenever you have a suspicion of mesothelioma and you're working towards a mesothelioma, please make sure you use multiple markers. And if at least two of them come positive, then you can confidently call it a tumor of mesothelial origin. And another issue that comes is distinction between reactive and malignant mesothelial proliferation. So for this, there are two new markers. One is BAP1 and another one is MTAP. So any loss of expression of nuclear BAP1 indicates that it is a malignant mesothelial proliferation and it is not a reactive proliferation. And even loss of expression of cytoplasmic MTAP indicates a malignant process. We can also do molecular testing. Homogeneous deletion of CDKN2A P16 by IHC indicates a malignant mesothelial proliferation over a reactive condition. So, and in a tumor like our case, we also need to differentiate it from pseudotumoral deciduosis. So, this kind of deciduosis usually occur in women of childbearing age group, but however they are also known to occur in postmenopausal women. So literature says that when you have high degree of cellular ATP and presence of mitosis, please favor a mesothelioma over a deciduosis. And even your IHC studies can help in differentiating the two entities. The decidual cells will express estrogen receptor and alpha inhibin. However, these markers are absent in your mesotheliomas, and your electron microscopy will definitely help in demonstration of the slender microvilli, which indicate a mesothelial differentiation. The other tumor will be a trophoblastic neoplasm. In this case, you can use HCG immunohistochemistry. In the right context, we'll be able to differentiate the two entities. And they also need to be differentiated from other entities such as an oxyphilic clear cell RCC, pleomorphic lung carcinomas, and even all your non-epithelial tumors such as your GIST, rhabdomyosarcomas, and melanomas, and all the differentials that were given for this case. And mesotheliomas, as you all know, in young adults, it is very rare. And the pathogenesis of pediatric and young adult mesotheliomas remain largely unclear. However, there are few fusions that has been reported, like one of which is the fusion between EWSR and FUS genes with either ATF1 or YYY genes. YY1 genes, which are unrelated to asbestos exposure or PAP1 abnormalities. And the other one is gene fusions involving ALK genes. And prognosis wise, this is a clinically very aggressive tumor with a median survival of 7 to 8 months. And in our present case, we followed up the child for almost 4 months. The parents decided to take treatment in their hometown. The child was on chemotherapy and radiation, and at 4 months she was still alive with disease, but later we lost the child to follow up. So I would like to show you this flow chart, which is something like an approach to your epithelioid cell tumors. So when you have an epithelioid cell tumor, we should do a battery of markers. The first panel of markers will include CK, vimentin, LCA, SAL4, S100, and SOX10. So if SAL4 is positive, it indicates a germ cell tumor. If LCA is positive, we work in the line of hematopoietic and lymphoid tumors. If SAL4 and LCA both are negative, then we have to do a cytokeratin. And cytokeratin or a sarcoma with a CK co-expression or a mesothelioma. If it's focal CK positivity, it still indicates a poorly differentiated carcinoma or even your sarcomatoid carcinoma, etc. If CK is negative and vimentin is positive, then you have to work with S100 and SOX10. S100 and SOX10 negativity, you will have to rule out all the other markers such as hematopoietic and lymphoid tumors and sarcomas. If they are both positive, then it will we'll have to think of melanoma, clear cell sarcoma, and nerve sheath tumors. So this is an extensive list of epithelioid soft tissue tumors that I have got from Elsinger, and we had all the differentials that is given in this list. But whenever you see an epithelioid tumor, we should also think of other tumors other than sarcomas, because we'll have to rule out a carcinoma, melanoma, a large cell lymphoma, and mesothelioma. So take-home points from this case would be: not all tumors with epithelioid morphology are sarcomas. We'll have to rule out carcinoma, melanoma, large cell lymphoma when we get a tumor with epithelioid morphology. And all the IHC for mesothelioma, as I have mentioned, there is no specific IHC for mesothelioma. So whenever are thinking of you want to rule out a mesothelioma, please use a battery of markers, and if at least two or three of them come strong positive, then you go with a mesothelioma diagnosis, and also do BAP1 and MTAP or molecular studies to confirm the same. And we need to have a proper clinical and imaging correlation with a high degree of suspicion, followed by necessary immunohistochemistry and molecular studies to make an accurate diagnosis. These are my references. Dr. Shivangi, any doubts? Dr. Shivangi, are you there?
Archana, shall we move to the next case?
Yeah. Yes, sir. Thank you, Dr. Shivangi, and thank you, Dr. Archana, for this case discussion. So let's quickly move on to case number 5, which will be discussed by Dr. Namita from Kidwai Medical Institute of Oncology. Dr. Namita, can you please share your screen and unmute yourself, please?
Yes, ma'am. Ma'am, is it seen?
No, Dr. Namita.
Now, ma'am?
Yeah, it's coming now. Yes, you can go ahead, please.
Good afternoon, everyone. I'm Dr. Namita M., final year postgraduate student from Kidwai Memorial Institute of Oncology, Bengaluru. I'll be presenting case number 5. Ma'am, my second slide is visible.
No, Dr. Namita. Can you just try? Are you moving to the next slide?
Yes.
Can you do one thing? Can you stop sharing and share
Yes,
the
ma'am.
entire
Yes,
screen again?
Now, ma'am?
Screen is visible. Can you move to the second slide?
Yeah, I'm actually moving.
We're not able to see. Dr. Aditya, can you see it, sir?
Dr. Namita, stop sharing, and this time click on the entire screen, not the PowerPoint. This is a request to all PGs, share your entire screen. Otherwise, we'll not be able to view your slideshow mode slides. Dr. Namita, when you click on share,
Yes, sir. Yes, sir. I'm.
Click on share, click on screen, not the PowerPoint. Namita, are you sharing the slide now?
Yes, sir. I'm sharing now. The slide number 1.
No, change it to slide number 2.
I've changed, sir. Slide number 2.
That's why we are not able to view the second slide. See, please don't hurry.
Yes, sir.
This time, click on share button, click on screen.
Screen, sir. I'm clicking
Screen.
actually.
Screen, and then the click on share
Share.
button.
I'm actually following the same steps, sir.
Change to the next slide now. Advance to the next slide.
Yes, sir. Is it seen now?
No.
Yes, it's visible, sir.
Yes,
It's
yes,
coming.
it's seen now. Yeah, go ahead.
Okay. The history provided was 41-year-old male with a history of right shoulder pain since 3 months. Actually, I'm not able to see, sir. Actually, yeah. With PET CT showing expansile lytic soft tissue lesion measuring 4.5 by 4 by 2.8 centimeter with cortical erosion and intralesional calcification. Coming to the microscopy, this is a whole mount view of H&E stained section showing a needle course of tissue. As we move to higher magnification in scanner view, we can see bony trabeculae which are rimmed by osteoblast with an infiltrating neoplasm composed of cells which are arranged in vague nodular or lobulatal architecture. This is a higher magnification of bony trabeculae with an infiltrating neoplasm. In this focus, we can see a complex proliferation of many vascular channels which are lined by plump epithelioid endothelial cell which coalesce to form a vascular lumina. In the periphery, we can see the slit-like vascular spaces. In the center of the lumen, in the center of the lobule, these cells are lined by plump endothelial cell, whereas in periphery, these small arterioles are lined by flat endothelial cells. Intervening stroma shows bland spindle-shaped cells arranged in vesicle. In a higher magnification, these cells are large, round to oval, with abundant deeply eosinophilic cytoplasm, vesicular chromatin with prominent nucleoli. In this focus, we can see these epithelioid endothelial cells protrude into a lumina, forming a hobnailing or tombstone appearance, beneath which we can see a scattered osteoclast type of giant cell. We can see here, this is a hobnailing effect of the cells. Higher par view of scattered intratumor osteoclast type of giant cell. The stroma shows chronic inflammatory cell infiltrate predominantly rich in eosinophils. Also seen are lymphoid aggregate in the background. Coming to the case summary, 41-year-old male with microscopy showing bony trabeculae with replacement of marrow elements by an infiltrative vascular neoplasm. The large dilated vessels are lined by plump epithelioid endothelial cell forming vascular channels. These epithelioid endothelial cells protrude into a lumen like a tombstone fashion. Bland spindle cells arranged in vesicle. Eosinophil-rich stroma with focal lymphoid aggregate. Intratumoral osteoclast type of giant cell. Mitosis was sparse. There was no areas of calcification seen. There was no areas of necrosis seen. With the above morphology and correlating with the radiology, my probable diagnosis will be vascular neoplasm, possibly epithelioid hemangioma of bone, also previously known as angiolymphatic hyperplasia with eosinophilia. My provisional differential diagnosis will be epithelioid hemangioendothelioma of bone. Since there was no myxohyalin stroma and there was no necrosis and there was no atypical mitosis in our case, I would like to rule out this entity. And I would like to confirm my diagnosis with immunohistochemistry with endothelial markers such as CD31, 34, FLI1, ERG, factor 8 related antigen, and CK for epithelioid cell and FOS or FOSB. If feasible, I would like to go ahead with molecular test for rearrangement of FOS or FOSB. Thank you.
Thank you, Dr. Namita. We'll now have Dr. Tripti who will discuss this case.
You're not audible here on this.
There is lag. Dr. Namita, can you see the PowerPoint presentation?
Yes, ma'am. I can see, ma'am.
Okay, so if in case you can't see, please tell us, okay?
Yes, ma'am. Sure, ma'am.
There is a question answer session at that time we can take up questions. Hi, Dr. Namita. Am I audible?
Yes, ma'am.
Yeah, so you've presented the case very beautifully. Everything was on point. I'll just take you through our perspective of the slides and what IHCs we did here to prove that what it is, what the lesion was. So history is a 41-year-old male with right shoulder pain since 2 months, PET CT expansile lytic lobulated soft tissue lesion. So the lesion was predominantly a soft tissue lesion which measured 4.5 centimeter in maximum dimension, and it was impinging on the scapula with cortical erosion and intralesional calcification. So these are the core biopsies which we received. Actually, this case was received as a block for review because outside somebody had reported it as metastatic adenocarcinoma and they were not able to identify the primary of this tumor. So when we saw the slides, we were able to make out these elongated structures which have nice lumina formation, which are lined by nice plump epithelial looking cells. And the intervening stroma has these spindle cells with a good number of eosinophils admixed. And you can see there are some lymphocytes and plasma cells as well. So if you look at these epithelial cells, these structures which are there, they are not mitotically active cells. They look very bland with prominent nucleoli, which actually rang a bell in our brains, whether we are really looking at a metastatic adenocarcinoma or is it something else we are dealing with. So again, in the same image, you can see these epithelial looking cells, which have a gland-like lumina at places. In the first go, anybody would have called it as a metastatic adenocarcinoma, but the milieu is very, very important here. It's rich in eosinophils and there are these spindled, elongated cells. So, Dr. Namita, could you name a few tumors which are eosinophil-rich tumors? Hello. Okay. Hello, Dr. Namita, am I audible?
Yes, ma'am. Mast cell sarcoma. Mastocytosis.
Okay. And Langerhans cell histiocytosis, Kimura's disease, Hodgkin's lymphoma, angioimmunoblastic T cell lymphomas, cutaneous lymphomas. Yeah, so there is an exhaustive list of all these tumors as well. So there in this another focus, you can see that this tumor is actually infiltrating the bony trabeculae. These bony trabeculae are lined by nice osteoblasts, and in the intertrabecular areas also you can see these vascular spaces which are lined by plump epithelioid cells. Again, the larger view of the same image. So the responses which we received were namely ossifying fibroma, biphasic synovial sarcoma, epithelioid hemangioma, LCH, calcifying aponeurotic tumor, metastatic adenocarcinoma, glandular synovitis, multiple myeloma, adamantinoma, fibrous dysplasia, osteosarcoma, and metastasis from fibrous lesion. Our thoughts were, since it's a tumor which is rich in eosinophils, which has a cellular stroma, is it an epithelioid hemangioma? The second thought was whether it's really a metastatic carcinoma with pseudosarcomatous stromal response and eosinophils are just bystanders. Third possibility, yes, biphasic tumor was our possibility, synovial sarcoma, because it is possible that those are actually epithelial glands and the stroma is, spindly. So it could be a biphasic tumor. And fourth, inflammatory myofibroblastic tumor. So let me take you through the IHC slides. So we started with a workup of metastatic adenocarcinoma since it was reported outside like that. Okay, so CK7, CK20 initially with the panel of all the primaries, namely lung, and then NKX 3.1 for prostate, CDX2 and SATB2 for colorectal and intestinal markers and so on. So look at the CK7 slides. Dr. Namita, is it positive, CK7?
Yes, ma'am. It's positive.
Yes, so CK7 is positive, nicely positive in those cells which are very epithelial looking, but the spindle cells are negative. CK20 is negative. Now going on to the primaries, like lung, intestinal, TTF1 is negative, CDX2 is negative, NKX 3.1 for prostate, negative, GATA3 for a breast primary, negative. Look at the SMA pattern. What do you observe in this, Dr. Namita?
Tram track. Positive, ma'am.
Yeah, so SMA is positive in outlining the these vascular kind of spaces. So it actually denotes that these vascular spaces have a thin pericyte coat, which we were not able to discern on light microscopic images itself. So SMA is taking up in this pericyte coat around these vascular spaces. So we moved on to a panel of mesenchymal tumors here, because now our only CK7 is positive, and as Dr. Archana pointed out, CK can be positive in your other mesenchymal tumors as well, especially the tumors which have that epithelioid kind of morphology. So we did Desmin, negative, S100, negative. SAT-B2 is only positive around these around these osteoblasts which are rimming the bony trabeculae, and also focally in the spindle cells. TLE1 for synovial sarcoma, it was completely negative, both in the spindle cells and these epithelioid cells. ALK1 for an inflammatory myofibroblastic tumor is negative. P63 is negative. CD34, if you look at it, these vascular spaces which are lined by plump cells are very patchy positive. The other vascular spaces, the thin ones, are actually positive, strong positive. So then we went on to our vascular markers. So vascular markers which we did here to confirm that it's a vascular neoplasm were CD31 and ERG. So CD31, as you can see, it has taken up strongly in these vascular lumina, which were lined by these epithelioid cells. They have taken up strongly, and it is positive. So we did another vascular marker to confirm that it's really a vascular neoplasm which we are looking at. So we did ERG. You can see ERG is strong nuclear positive. So what is the diagnosis, Dr. Namita? As you correctly pointed out, it is an epithelioid hemangioma. It is a benign vascular neoplasm, and there was a lot of debate before that whether it's a reactive condition or a neoplastic condition. But lately they've come to conclusion that yes, it's a neoplastic condition, but it is benign. Most often it is benign in nature. We also did a Ki-67 proliferative index to ascertain whether these epithelioid cells are actually proliferative or no, and it was actually low. It was less than 10% in these cells. So epithelioid hemangioma is also called as angel lymphoid hyperplasia with eosinophilia, or nodular angioblastic hyperplasia with eosinophilia and lymphofolliculosis, histiocytoid hemangioma, inflammatory angiomatous nodule, or atypical or pseudomyogenic neoplasm. So the essential features here we have to look for is numerous stromal eosinophils and lymphoid reaction with follicles in most of the cases. Most frequent sites are head and distal extremities. All cases show diffuse strong expression of vascular markers. In this case, CD31 and ERG, as I showed you. False rearrangements are seen in a third of epithelioid hemangiomas across different locations and histologic variants. So these are the various sites it can occur. The clinical features, usually it happens in young adults, 20 to 40 years, and women are more often predisposed than men. It may present as skin plaques also, and it is seen that usually the skin lesions, they are not associated with the central artery, and the epithelioid cells which are lining these vascular spaces are less plump than the cases which are seen in the deep soft tissue or the bone. Okay, so subcutaneous lesions may be confused with lymph nodes because they have a very, very nice circumscription. Like in our case, we have a circumscribed lobulated mass. So subcutaneous lesions are generally confused with lymph nodes because they have a good circumscription and prominent lymphoid reaction on low power. So this is the low power image of the skin slide, wherein you can see that there is a good amount of lymphoid infiltrate around the tumor and the central eosinophilic area, which is actually rich in vessels, which are lined by these plump endothelial cells, and they are surrounded by the spindly stroma, which is very rich in eosinophils. It is very important to know the various subtypes of epithelioid hemangioma, because always a classical slide won't appear to you. This is the solid variant of epithelioid hemangioma, wherein you have to differentiate it with angiosarcoma. You will not be able to see nice vascular spaces which are lined by epithelioid cells, but atypia, mitosis, necrosis, all that has to be looked for to rule out an angiosarcoma. Then epithelioid variant of hemangioma, and spindle cell variant of epithelioid hemangioma. So all these variants do exist. Please go through the slides. All these images have been taken from Enzinger itself. So as Dr. Namita had showed, that these cells are generally do show that hobnailing of cytoplasm within the lumen, and at times these tumors have also been seen involving the wall of the large vessel, and this phenomena should not be equated with malignancy. So the differentials which are to be considered are, first and foremost, Kimura's disease. Kimura's disease most commonly happens in middle-aged people, that is middle-aged Asian men, and they have elevated serum IgE levels. Peripheral blood eosinophilia is quite common. There are a good amount of lymphoid follicles generally associated with Kimura's disease, and if you're lucky enough, you would see necrosis of germinal centers and Worthen-Frankeldy type of giant cells. The important fact here to remember is they are not associated with Foss rearrangements like an epithelioid hemangioma. So next, differential epithelioid hemangioendothelioma. Hemangioendothelioma usually is composed of chains or cords of epithelioid cells. The stroma is very important. It is generally based in a myxoid or a hyaline stroma, unlike an epithelioid hemangioma, which is placed in a eosinophil-rich, very spindly kind of stroma. The cells in epithelioid hemangioendothelioma, they have intracytoplasmic lumina, and they might at places show RBCs as well in those lumina. No well-formed vessels are usually noted. And the very important IHC marker you can do to differentiate epithelioid hemangioendothelioma from epithelioid hemangioma is CAMTA1 IHC. So in this case, I think we don't have an in-house CAMTA1, so we had suggested CAMTA1 IHC to be outsourced, and it came out to be negative. So this is another picture of epithelioid hemangioendothelioma. You can see the cells. They have abundant vacuolated cytoplasm and intracytoplasmic lumina, which are standing out. The next important differential is epithelioid angiosarcoma. It is very important to differentiate both these entities because one is malignant, the other one is benign. So for diagnosing this malignant entity, you need to see prominent solid areas of growth, coagulative necrosis, brisk mitotic activity, significant nuclear atypia, and a dissecting growth pattern, unlike an epithelioid hemangioma, which will usually be a circumscribed tumor. That's all. Thank you so much. If you have any questions, please feel free to ask.
Thank you, Dr. Namita and Dr. Tripti ma'am, for that presentation. We'll move on to case number 6, which will be discussed by Dr. Akanksha Hegde from MS Ramaiah Medical College, Bengaluru. Dr. Akanksha, can you please unmute yourself?
Yes, ma'am. Is it visible?
Yes. Can you just start your presentation? Go to the second slide.
Just a second.
Yeah.
Yeah. Good afternoon, everyone. I'm Dr. Akanksha from MS Ramaiah Medical College. I'm presenting case number 6. The case history given was 20-year-old female, clinically nodule over the right index finger with spreading papules and pustules to the adjacent dorsal hand. Skin biopsy was sent. The scanner view showed that the structure of skin with epidermis and dermis. Epidermis shows acanthosis and focal spongiosis. Upper dermis showed areas of melanin incontinence and sheets of infiltrating tumor cells extending up to the deep dermis. The tumor cells are round, epithelioid and spindle shaped, showing moderate pleomorphism, high NC ratio, hypochromatic to vesicular nuclei, prominent nucleoli, and moderate eosinophilic cytoplasm. 1 to 2 mitosis were noted per high power field. Also seen are intracytoplasmic vacuoles with RBCs and vasoformative channels. The spindle cell proliferation appeared to surround the vessels and also seen admixed lymphocytic infiltrate. Periadnexal inflammation was also noted. Focal query necrosis areas with adjacent healing granulation tissue was made out, and also hyalinized stroma was seen. Summary of the slide. Upper dermis shows infiltrating tumor cells extending up to the deep dermis. Tumor cells are arranged in sheets and nests. Cells are round, epithelioid and spindle shaped, show moderate degree of pleomorphism. 1 to 2 mitosis per high power field seen. Vasoformative channel seen. Intracytoplasmic vacuoles with RBCs seen. Focal necrosis, query necrosis with adjacent healing granulation tissue noted. Coming to the differential diagnosis, the first one we considered was malignant vascular tumor with epithelioid morphology favoring Kaposi sarcoma. The favoring features are spreading nodules and papules, epithelioid and spindle cell proliferation, vasoformative channels and intracytoplasmic RBCs, as well as mitosis. Points against is atypia usually in Kaposi sarcoma is mild. IHC that can be done to confirm are endothelial markers like CD31, 34, ERG, and specific marker HHV8. The second differential is malignant melanoma, and the site favoring this acral nodule in the history given, and sheets and nests of moderately pleomorphic tumor cells, which are spindle shaped and epithelioid type of cells were seen, and mitosis is also a favoring point. But points against are usually malignant melanoma doesn't present as papules and pustules, and purely dermal melanoma incidence is only 0.8% of the malignant melanomas. IHC that can be done to confirm are S100, Melan A, HMB45. The final diagnosis based on the morphological features favor malignant vascular tumor with epithelioid morphology could be Kaposi sarcoma. However, IHC is required to rule out malignant melanoma. Thank you.
Dr. Akanksha, can you see the presentation?
Yes, ma'am.
The slides are moving.
Yes, ma'am.
Thank you, Dr. Akanksha. This is Dr. Vidya here. So it was a very good presentation. So you've explained most of the points. Let me just quickly take you through some more history. So this was a 20-year-old female, clinically nodule over the right index finger with spreading papules and pustules to adjacent dorsal hand, and a skin biopsy was done. Basically, this patient presented to the dermatology OPD here, and the clinical diagnosis are put up. You can see that they had varying differentials that included deep fungal infections, porotrichosis, cutaneous TB, atypical mycobacterial infections, sarcoidosis, neoplasia. And apparently the patient had these pustules and nodules over a period of more than 1 year. So these are the differential diagnoses that were offered, starting from varying conditions like benign conditions, including lichen planus, to NHL, spitzoid melanoma of childhood, ameliotic melanoma, epithelioid hemangioma, cutaneous ALCL, rheumatoid nodule, hemangioendothelioma, melanoma, spitz nevi, compound nevi, dysplastic nevi, sporotrichosis, fungal infection, DFSP. The list is endless. So we also have mastocytosis as well. So this was the clinical pictures that I wanted to demonstrate here. So you can see that definitely Here you can see a lot of ulceration and this papillar, pustular, nodular type of lesion. So it is varying. All right. So you can see that there are some satellite lesions as well. So you can see that the elbow joint, there is also an ulcer. So when this patient came to us and we took these images, in fact, we realized how extensive the disease was already. So this is like how you mentioned, the epidermis showed mild spongiosis. In fact, we had given 2 skin biopsies because they were done from 2 different areas. So in the first one, you could see that there are areas of necrosis. You said questionable necrosis. I would say definitely there is necrosis, which is there in the mid to upper dermis, and also there were these scattered spindle cells. So you can see that the dermis is a very showing very active pathology out here rather than the epidermis. So we know that something is happening here in the dermis. So let's go over to other areas. Now you can see this spindle cell proliferation. Obviously, we're looking at something neoplastic. Now, is this benign or malignant becomes the next question. You can also see that there are entrapped adnexal structures in between the spindle cells along with moderate to dense lymphocytic infiltrate in the stroma. So the tumor has elicited an inflammatory response as well. You can see here higher power view of the areas of coagulative necrosis that we are seeing, and also these atypical spindle appearing cells. Some of them do have some tapered cytoplasm. So you can see that I've marked a mitosis. Mitosis was not brisk, though the cells look pleomorphic. And also you can see some of them showed just occasional nucleoli which appear basophilic. What is the kind of nuclei that you see in melanomas? Generally, they are very prominent eosinophilic nucleoli. Many times, some spindle cell melanomas definitely do not exhibit nucleoli which are prominent. Were you able to see any cytoplasmic melanin pigment in the tumor cells?
Not much. Melanin incontinence was.
Yes, you're absolutely right. There was absolutely no melanin pigment within the tumor cells cytoplasm. It was mainly melanin incontinence because there was some basal vacuolar degeneration in the epidermis. So let's move on. We also we did fungal stains because when we initially told that this is a spindle cell tumor to the clinician, they were aghast with the diagnosis. They said, no, it cannot be. We are still thinking of deep fungal infection. So we did a PS and GMS stains for fungal elements which were negative. I have received a couple of differentials of sporotrichosis and all. But definitely there are no fungal elements seen in the slides that we have provided. So you can see now that we have IHC staining for cytokeratin. I have also included the adnexal structure, which is your internal control here. And also, what is this good marker? It is CD34. So now, do you want to change your diagnosis? I've shown you cytokeratin and CD34. Will melanoma have CD34 reaction?
No, ma'am.
No. Okay, yeah. So this is a tumor which is having a dual staining pattern with cytokeratin, which is an epithelial marker, and CD34, which is generally a mesenchymal marker, and especially so for your sometimes for your endothelial cells as well. So we did a whole host of other markers. We also had a differential diagnosis of melanoma, but not really specifically when we did not see the cytoplasmic melanin pigment, though amelanotic melanoma will still be a possible differential diagnosis. But if you see, epidermal involvement was not there at all. So S100 we did, which is a primary screening marker for melanoma, and that was negative. We did CD31 because it's a specific endothelial marker, which is again negative. So it rules out a vascular tumor. And Desmin and SMA were additionally done to rule out other tumors like pseudomyogenic hemangioendothelioma, smooth muscle tumors, etc., which were all negative. And as I said earlier, fungal elements were not identified even on the special stains which were performed. We did a vimentin. So this tumor expresses both cytokeratin and vimentin. Ki67, you can see that there were some hotspots, but the Ki overall index was around 20%. It was not exceeding 20%. And we also saw some areas with dense lymphocytic infiltrate. So please don't be taken by this image because we know that lymphoid cells are also proliferative in nature and they can exhibit Ki expression. So now the magic marker that we did to prove our diagnosis, you can see that there is some nuclear staining. Okay, you can see my pointer.
Yes, ma'am.
Yeah, so this is basically the adnexal structure that I've included in all my slides. So it is taking up the staining. But do you see the spindle cells in the background? Have they taken up the staining?
No.
No, good. Now a higher power image. So these are few of the endothelial cells that have taken up the staining. Your adnexal structures again here. So these become our internal control. So what are we looking at? Here we are looking at loss of expression of a marker, and it is a nuclear marker. Do you want to second guess anything? This is another image. I want to show the epidermis showing nice internal control staining. And as I showed in the earlier slides, the spindle cells are all negative. Do you want to take a guess on what marker this is, which is showing loss of expression in tumor cells? Okay. Yes, very good. Excellent. So this is INI1. So there is loss of INI1, and now you have CK and CD34 staining. So what would your diagnosis be? Okay. So this was our diagnosis, epithelioid sarcoma. This is classical type. Okay, so this is also known as distal type epithelioid sarcoma. There is definitely loss of INI1 expression, and this is one of the classical tumors which show loss of expression of INI1. Coming to the discussion, we all know that it is basically a tumor of uncertain histogenesis because it exhibits epithelioid cytomorphology and it also exhibits an epithelial phenotype. So here we have two variants, that is classical or distal type and proximal or lateral type. So the classical type generally shows a pseudogranulomatous growth pattern. As you could see, there were areas of necrosis and surrounded by these proliferating spindle cells, which elicits a sort of a granulomatous growth pattern. And like in our case, this was these are known to be in the distal upper extremities, predominantly arising in the fingers and hand, and they are generally solitary or multiple, slow growing, usually painless, firm nodules, and they occur in adolescents and young adults. Our patient here was 20 years of age. So the proximal or the large cell type, like we've already had an extensive discussion on Dr. Archana's case of the malignant mesothelioma, where she explained on how do we differentiate all these. So epithelioid sarcoma is a close differential for all your other epithelioid tumors, and especially so the proximal type of tumor. So here they are generally the tumor cells are arranged in nests and sheets with large epithelioid cells, and they are more infiltrative in nature, and they occur in a slightly elderly age group. And here they occur most often in the deep sites, that includes your pelviperineal region, genital and inguinal tissue, buttock and hip regions. So these can metastasize to nodes, and we all know that it is INI1 or SMARCB1 which is lost in these tumors, and this can be detected by IHC with loss of INI1 expression or by FISH, which demonstrates biallelic deletions. But there is an extreme minority of epithelioid sarcomas which can show retention of INI1. Then it becomes difficult. You will have to rely on the other markers, which includes your SMARC-A4, that is BRG1, then SMARC-CC1 and SMARC-CC2, and these are known to have an adverse prognosis. So we all know that, as in our case, the classic ES shows spindled and epithelioid cells, and here it forms a necrotizing nodule which can actually grow along the lymphatic spaces and cause a lot of lymphedema also for the patient. And like you rightly mentioned, you had a differential diagnosis of a vascular tumor, because sometimes these tumor cells can show cytoplasmic vacuoles, but definitely here in this case there was no vasoformative channels that we could identify. There were some RBCs, some plump endothelial cells and vascular spaces with RBCs, which you can mistake for tumor cells in this case. Mitotic activity is low, and sometimes these tumors also show some dystrophic calcification. So this is an image that I borrowed from the WHO 5th edition. This is for the proximal type, where you have large epithelioid cells which are generally arranged in syncytial sheets or nests. So that is how these cells are seen, and rhabdoid cells are seen. So this is a close differential for your your extrarenal rhabdoid tumor, especially when it is occurring outside of the kidney location. So when we come to prognosis and treatment, generally many of these patients may not do well. The wide surgical excision is a mainstay of treatment. Many times palliation is given, but the response is of short duration and the relapse rates are very high. So the 5-year and 10-year overall survival rates for these patients are between 45 to 70%. And also, even with some R0 surgery, there is chances of recurrence. Unfortunately, in our case, the tumor had spread till the shoulder and there was to be a morbid surgery, which the patient really could not withstand, and the patient was referred to another center and they decided to go back to their hometown. So IHC, as I said, like in our case, they can stain for CD34 along with your other epithelial markers, loss of expression of INI1. Please note, ERG can show expression and this can lead to a false positive diagnosis of a vascular tumor. So the differential diagnosis, like rightly mentioned, one of the most common differential diagnoses that you need to entertain, especially when you see the skin nodules, is your rheumatoid nodules. Here they can show extensive necrosis, which is because of the degeneration of the collagen and also necrosis. So, and they are surrounded by spindle cells, which you should not mistake for tumor cells because these are generally histiocytes and they mark for CD68. Carcinomas, they have retention of INI1. There is no loss of INI1. Extrarenal rhabdoid tumor is a differential diagnosis for your proximal type of epithelioid sarcomas. Here it becomes very difficult to identify, but the main marker will be CD34 because CD34 is generally negative in extrarenal rhabdoid tumor. But these cells again show loss of INI1 expressions. But there may be confusing cases where you will have to go back to your molecular studies like NGS to identify the molecular alterations between extrarenal rhabdoid tumor and your proximal type of epithelioid sarcoma. Malignant melanoma will not stain for CK, it will stain for your S100, SOX10 and HMB45 and will show INI1 retention. Epithelioid MPNST is one other tumor which can show loss of INI1. So here you need to be careful, but you have other ample markers like your S100, SOX10 or your histone marker, that is your H3K, ME3. So there are going to be other markers which are going to help you in diagnosis. Epithelioid angiosarcoma, already Dr. Tripti mentioned to you. Myoepithelial carcinoma is another tumor which can show loss of INI1. Here they stain for S100, but there is written, but they do not stain for your CD34. Pseudomyogenic hemangioendothelioma, obviously it has a certain pattern. They can stain for your CD34 and your desmin along with ERG, but here these cells show retention of INI1. So as PGs, you need to know the list of INI1 deficient tumors, which will come in handy. So this is a list I've made. You can make a note of this. This includes various tumors, which I've already mentioned, and few additional ones include your extraskeletal myxoid chondrosarcoma, polydifferentiated chordoma, and epithelioid schwannoma. We all know epithelioid schwannoma is benign. So obviously you'll not think of a malignancy in that case. So I hope we have come from an area of confusion to clarity. Thank you. Over to Dr. Archana.
Thank you, Vidya ma'am. Okay, so now moving on to the next case. That's case number 7, which will be discussed by Dr. Kalyani from KIMS, Bangalore. Dr. Kalyani, can you please?
Yes, ma'am.
You're on two. I'm getting an echo from your end, please.
No, ma'am. I'm opting only one window, ma'am.
Are you on two devices?
No, ma'am.
Is anyone else unmuted?
Can I share my screen? Hello, ma'am.
Yeah.
Is it visible? Ma'am, is it coming, ma'am?
Yeah, but I think you're on two devices or someone else is unmuted because I'm getting an echo.
No, ma'am. I didn't log in any other device.
Are you on two screens?
I'll just check, ma'am. No, ma'am, only one. Only one.
Okay, fine. Go ahead. Go ahead, please.
Okay. I'm Dr. Kalyani, third year postgraduate, Kempegowda Institute of Medical Sciences, Bangalore. History given was 16-year-old female, anemia under evaluation. So this is a bone marrow aspiration smear, and it is a hypocellular marrow, predominantly of bone marrow cyanous blood, and we can see a few particles here. So in this lower view, you can see predominantly the erythroid series, you can see severe erythroid hypoplasia, and myeloid series, you can see it is now appearing normal, and almost all stages of maturation can be seen. You can see mature neutrophils, myelocytes, metamyelocytes, etc. And you can even see a megakaryocyte. This is another field showing similar features. Here also you can see you are not able to see any erythroid precursors, whereas myeloid series can be seen and the megakaryocyte can be seen. Here in the erythroid series, you can see one pro-erythroblast which is having a deeply basophilic cytoplasm, and you can see fine cytoplasmic projections. And whereas the myeloid, and we are not able to see any other mature erythroid precursors. Whereas myeloid series and myeloid series appears normal and shows all stages of maturation. This is I'm focusing on gen pro-erythroblast having deeply basophilic cytoplasm, high NC ratio, and you can see one nuclei. This is another focus, another pro-erythroblast, which is gen pro-erythroblast having deeply basophilic cytoplasm and having cytoplasmic projections and a nucleoli. And this is another erythroblast having fine cytoplasmic vacuolations and cytoplasmic projections in the form of pseudopods. This is gen pro-erythroblast showing megaloblastoid nuclei, which is the sieve-like or open chromatin having 3 nucleoli. So with all this, we can conclude that in the erythroid series, we are seeing severe erythroid hypoplasia with predominantly gen pro-erythroblast, with some having megaloblastoid nuclei and few of them having cytoplasmic projection, and there is maturation arrest. Myeloid series appear normal and shows all stages of maturation, whereas megakaryocytes are seen and appear adequate. So given the history of a 16-year-old female having with the bone marrow having severe hypoplasia of the erythroid series and normal myelopoiesis and megakaryopoiesis, a diagnosis of pure red cell aplasia can be considered. And pure red cell aplasia can be constitutional, which is Diamond-Blackman syndrome, and it can be acquired since the age is around 16 years. Congenital causes can be ruled out, and usually it is a case, and it may be a case of acquired pure red cell aplasia, which can be due to multiple causes like parvo B19 infections, or it can be due to any autoimmune diseases or underlying any lymphoproliferative disorders. Thank you. Hello, ma'am.
Yeah, can you mute yourself?
Yes, ma'am.
Is it visible? Dr. Kalyani, is it visible?
Yes, ma'am. Yes, ma'am. It's visible.
Yeah, okay.
Good afternoon, everyone. So thank you, Dr. Kalyani. You have done very good job. So coming to case 7, we have received many differential diagnoses for this case. So I have listed those differential diagnoses here. Many of you called it as childhood myelodysplastic syndrome followed by parvovirus induced pure red cell aplasia, and few of you also had called it as chronic myeloid leukemia, acute leukemia, hemophagocytic lymphohistiocytosis, aplastic anemia, and hairy cell leukemia. So let's discuss this case and we will see what was the final diagnosis made in this case. So our patient is 16-year-old female who was a known case of Ewing sarcoma, has received treatment in the form of surgery as well as chemotherapy, had presented with progressive pallor and anemia. She had also received multiple blood transfusion, around 15 to 16 units in the past 6 months. So in the CBC, the child had anemia, which is normocytic normochromic indices, and other parameters were normal. Apart from anemia, this patient had marked reticulocytopenia. So reticulocyte count was less than 0.1%. So in order to rule out other causes of anemia, various other investigations have been carried out, like hemolytic anemia workup, serum iron profile, vitamin B12, folate, erythropoietin levels. Everything came out to be normal or negative. So bone marrow examination has been planned for this child, and bone marrow was done. So this is the aspirate. The bone marrow aspirate was it was hypocellular particulate, and if we see, we could see the there is increase in myeloid erythroid ratio, mainly due to the marked erythroblastopenia, as you rightly said. So in this case, there is marked erythroblastopenia, and you could also see these kind of large blood cells, which are the pro-normoblast or giant erythroblast. Also, you could appreciate some inclusions, and there are some bare nuclei which also showed some inclusions. This is another representative image which I got from the ASH image bank. So, Dr. Kalyani, can you please tell what are these inclusions and where could you see these inclusions?
This is intranuclear inclusions which can be seen in Parvo B19 virus, which is well appreciated in bone marrow biopsy rather than in aspirate.
It could be appreciated in the bone marrow aspirate also. Okay. Yes,
Yes,
good.
ma'am. But
So bone marrow biopsy, it showed decreased erythroid filling.
Dr. Kalyani, please mute yourself.
Okay. So it also showed giant erythroblast and inclusion. So we have suggested parvovirus B19 in this case, and we have asked for the B19 serology. So further investigations have been done, and parvovirus B19 DNA was positive in this child, and they have given IVIG. So after the child has received the IVIG, further hemogram showed improvement in the hemoglobin as well as in the reticulocyte count. So based on all these features, the final diagnosis made in this case was the parvovirus induced pure red cell aplasia. So coming to the discussion, so pure red cell aplasia is a disorder which had normocytic normochromic anemia, severe reticulocytopenia, and marked absence of erythroid precursors in the bone marrow. So we could see many causes for this conditions, could be congenital or acquired. In the acquired also there are primary secondary causes, and B19 parvovirus infection is the most common among the secondary. So it is an underproduction anemia. Usually the absolute reticulocyte count will be less than 10,000 per ml, and the percentage will be less than 1%. And in the bone marrow, the erythroblasts are usually less than 1%. And then you could also get 5%, but it won't exceed the 5%. Even those 5% will be your pro-erythroblast, like in our case. And in cases where if we see the large pro-erythroblast with vacuolated cytoplasm and pseudopodia, then these are all the pathognomic, or it is suggestive of B19 parvovirus infection. So coming to parvovirus, it is a single-stranded DNA virus, and its infections lead to many clinical manifestations, including pure red cell aplasia. So it mainly targets the early erythroid precursors through the P blood group antigen receptors, which leads to the apoptosis and cell death of those erythroid precursors, which leads to anemia. So and it's most commonly observed in immunocompromised patients, especially in HIV positive cases, chemotherapy recipients, and organ transplant patients. So we had some case report also similar to our case. There is we could find case report in the literature. So I conclude that this case highlight a need to investigate for parvovirus-induced PRCA in a patient who had presented with chronic anemia, reticulocytopenia, erythroblastopenia in the bone marrow, especially in the background of immunocompromised status. Thank you.
Thank you, Dr. Kalyani and Durga ma'am. So let's quickly move on to the next case. That's case number 8, which will be presented by Dr. Sabna from A.J. Shetty Institute of Medical Sciences. Dr. Sabna, can you please share your screen and unmute yourself? Dr. Sabna, can you please unmute yourself? Dr. Sabna?
Dr. Sabna, you're not audible.
So I think she's
your
unable to.
microphone is not connected to the right. Yeah. Just change the microphone settings, Dr. Sabna. Change to a different device. Use the internal, not the speaker, microphone. Use internal built-in microphone. All right. Just click on disconnect. Done. Dr. Archana will move to the next case.
Yes.
I'll train her how to I'll get her
Okay.
audio.
Okay, sir. Then we'll move on to case number 9, which will be discussed by Dr. T. Sai Shrija from Malla Reddy Institute of Medical Sciences, Hyderabad. Dr. Sai Shrija, are you there? Dr. Sai Shrija.
Yes, ma'am, I'm there.
Yes, can you please? Yes. Okay, yes, you can go
Good
ahead.
afternoon. I'm Dr. Sai Srija, final year postgraduate from Malla Reddy Institute of Medical Sciences. I'll be presenting case number 9. So the history given is 4-year-old male liver biopsy. So microscopy, the findings are hepatic artery dilatation and there is bile ductular proliferation. And on another section, there is severe bile ductular proliferation, that is more than 15 ducts are proliferated. In the other section, there is bile ductular proliferation and bile plugging is also seen. And periportal fibrosis and mild lymphocytic infiltration is observed. And hepatocyte degenerative changes are seen. And features are of cholestasis and ductular proliferation and fibrosis. And ballooning degeneration and rosette formation at focal areas is also observed. So my differential diagnoses are progressive familial intrahepatic cholestasis, biliary atresia, fibrosing cholestatic hepatitis, primary sclerosing cholangitis, and chronic hepatitis with storage disorder. So indications for liver biopsy are abnormal liver tests that are not explained by other methods and systemic or metabolic disorders like Gaucher's-Wilson's disease and evaluation or grading or staging of chronic liver diseases in chronic hepatitis, viral hepatitis, alcoholic or non-alcoholic liver disease, cholestatic liver disease, cirrhosis, and primary metastatic tumors and post-transplant biopsies. and approaches to identify portal tracts, hepatic venules, and everything between them. That those are hepatocytes, sinusoidal cells, Kupffer cells, and identify abnormality based on the architecture, portal tract, parenchyma, and special stains to confirm the diagnosis and correlate with the clinical context. Thank you.
Thank you, Dr. Shrija.
Yes.
Yeah, that was a good presentation. So
Thank you.
We received a feedback telling why they have given us only a single sentence history, 4-year-old male child, liver biopsy. Yeah, sometimes that is all what we get. And then the pathologist has to go back, find everything from the clinician, do the homework. So a lot of work lies on in the hands of the pathologist, including radiology, LFT, everything. Okay, so initially we also many times we come across liver biopsies, renal biopsies, etc., and even sometimes even skin biopsies where nothing will be mentioned, or sometimes we may get pages of history. So this is how you will need to learn how you're going to practice your pathology in future. So many times you need to go back, talk to the clinician, discuss with them why you have sent us only such a small history. So now these are the differential diagnoses that we have received. Many of them have given biliary atresia, extrahepatic biliary atresia, glycogen storage disorder, von Weinberg complex, then some cholangitis lenta, alpha-1 antitrypsin deficiency, Caroli's disease, PBC, bile duct hematoma, congenital hepatic fibrosis, duct plate malformations, Gaucher's disease. Just to tell that this is definitely not glycogen storage disorder or Gaucher's disease. There was some very mild feathery degeneration of the hepatocytes, but definitely no storage cells seen in the biopsy. We had put up this biopsy because it's an interesting case and one may rarely come across during their postgraduate training. And this is for a pattern diagnosis and analysis. So as you can see, like how Dr. Shrija already mentioned, this is basically we are seeing lot of ductal proliferation or ductular proliferation. You can see that the hepatocytes are all still seen in some lobular pattern of arrangement only. What you showed, that dilated area, was not an artery, it is basically a central vein that we were looking at. Okay, but what do you see? You see a lot of these blue areas. Okay, so these are your bile ducts which are almost hugging the hepatocytes or the interface, that is the ductal plate areas. So when we look at the higher power, the hepatocytes look almost near normal, a nice pink cytoplasm. Occasional cells are showing some vacuolations, but there were no rosettes. Rosettes is a different pattern that you may generally see in conditions like your autoimmune hepatitis and other lesions. Okay, and no storage cells. Storage cells, glycogen storage disorder is something that is very characteristic under low power. So you are going to see that cotyledon appearance. Okay, that is called as plant-like appearance. Now here, what are you seeing? Like how you mentioned, there is bile in many of these bile ducts that are seen, but many of them are, yes, but many of them are still having just bland lumina without any bile. So this is what I would say, a characteristic wreath-like formation of the bile ducts which are arranged around the hepatocytes. Okay, and you can see this greenish brown bile which is seen in one of the bile ducts. There is no significant inflammation either in the lobules or in the portal tract. And obviously what you mentioned was right. There is portal tract fibrosis, which is very early. You can see this portal tracts. This is a trichrome stain with nice blue and pink areas out here. So portal tracts are expanded and there is setting in of the fibrosis. But what is a distinct feature that you can make out? There is no significant fibrosis within the lobules. Okay, so we have ductular proliferation, or what we call as duct plate malformation, rather than ductular proliferation, without any lobular inflammation or portal inflammation. Okay, so we went back and took some additional history. This case was a known case of autosomal recessive polycystic kidney disease with clinical symptoms of portal hypertension and hypersplenism. So our final diagnosis on the liver biopsy, see, liver biopsy is some organ where, especially medical liver biopsy, we never give a diagnosis. We give what is the pattern. be it anything like chronic active hepatitis, then these could be the differentials. So that is how you always interpret a liver biopsy, and the liver biopsies has to be read in consultation with your background clinical history, your ultrasound findings, your radiology, other radiology findings, your LFTs, your autoimmune panel workup, then your like your torch infection, especially neonate biopsies and genetic studies, along with a discussion with the gastroenterologist or the hepatologist. So this was given as a diffuse ductal plate malformation in favor of congenital hepatic fibrosis. So just a brief discussion on this CHF or congenital hepatic fibrosis. We know that this generally occurs in conjunction with your autosomal recessive polycystic kidney disease. This our patient also had a PKHD1 gene mutation, and clinical presentation can be in older children, adults, and adolescents. Like in our case, these patients are known to have hypersplenism with portal hypertension, which can cause varices and cholangitis. Here, the duct plate malformations of CHF can be associated with Caroli's disease, where we have segmental dilatation of the larger intrahepatic bile ducts. So at that time, it is also known as Caroli's syndrome. So we know that it can occur in other syndromes like Meckel-Gruber, skeletal dysplasias. This is basically because there are mutations in genes which encode for your primary cilia. So there is a ciliary ciliopathy or a hepatorenal ciliopathy. So you can see that there are multiple cysts in the kidney and the liver also in these conditions. So clinical manifestations, as I said, will be mainly because of your portal hypertension. Hypersplenism can cause low platelets and WBCs, and bleeding, varices, pulmonary hypertension. The liver is generally enlarged and it is very hard to palpate. And also these patients will have a palpable spleen. But whereas your liver enzymes, including your ALP and GGT, remain normal. And in cases of the dilatation of your larger bile ducts, it can lead to inspissated bile and cause cholangitis. The patient may present with fever and elevated blood cell counts, etc. So microscopy, like in our case, we're going to see progressive portal tract fibrosis. And as I said, circumferentially arranged or wreath-like pattern, which is reminiscent of your embryonic duct plate. And we can see bile ducts which show inspissated bile or eosinophilic material, but absolutely no inflammation unless and until there is a cholangitis. So this is something that I borrowed off the net. So here you can see the pathogenesis. This is basically an epithelial mesenchymal transition that happens. So you have the hepatocytes which are closely associated with your portal vein mesenchyme. So these are the ones which start forming the bile ducts in the fetal period. So you have the portal vein and the cells associated with the portal vein, where a single layer of cells are first laid out, and finally a double layer is formed, and there's a cleft-like formation between the hepatocytes and the portal vein. So once it starts forming, they're still attached. That is a period of 18 to 40 weeks of the gestation period. So the bile ducts then get dissociated and they start centralizing in the portal tracts. But whereas when you have this genetic defect, due to some unknown reasons, this malformation occurs, and these bile ducts do not dissociate themselves from the interface or the portal limiting plate. So they still adhere and form this reed-like configuration around the hepatocyte lobules, and there is going to be excessive proliferation. So this is one review article that I would recommend the PGs to read. So it's a very nice article which explains both congenital and hepatorenal fibrocystic syndromes, and also gives in a lot of pathogenesis. So you mentioned extrahepatic biliary atresia and all. There generally you will see very haphazard proliferation of your bile ducts. The arrangement will not be like this. There will be associated inflammation. When you mean cholestatic injury, that means there should be intrahepatic cholestasis. There should be your canalicular or sinusoidal cholestasis. But here, what you're seeing is that the hepatocytes are absolutely normal. There is no intrahepatic cholestasis. Generally, PFIC, then your EHBA, then your neonatal giant cell hepatitis, all these paucity of bile ducts, etc. They're all part of a spectrum of diseases, especially seen within 1 year of age. And for PFIC, you should generally have a familial correlation as well. But in this condition, as I said, the patient was an already known case of autosomal recessive polycystic kidney disease. Okay, and the treatment generally is more symptomatic. Photosystemic shunts for portal hypertension, treatment of varices and endoscopic surveillance, and antibiotics for cholangitis. Generally, liver transplantation is indicated only in severe cases. Okay, so this was a case of hepatic fibrosis. Thank you.
Can we proceed to case number 10? Kindly note that case number 10 will be discussed directly by the faculty, Dr. Varsha.
Hello, am I audible? Am I audible?
Yes, ma'am.
Yes. Okay. So we'll go ahead with case 10. This is the history that we provided. A 12-year-old male, excision biopsy was done of a lower eyelid swelling. These are the responses we received. Majority of the responses were juvenile xanthogranuloma. The other responses were chalazion, xanthoma, fungal granuloma, and giant cell angiofibroma. So this was the slide that we gave. So you can see a lesion, you can see a skin lesion, right? The epidermis appears a little flattened, and it looks like the dermis has a diffuse infiltrate. So we'll go to the higher power. Epidermis looks flattened. The dermis shows a diffuse infiltrate. Lots of giant cells are visible at this power. And the intervening stroma, we can see some fibrosis, scattered inflammatory cells, and lots of these giant cells. So we go higher power. You can see these giant cells. These are characteristic giant cells. They call two-tone giant cells. So you can see that they have a ring-like nuclei and a eosinophilic cytoplasm in the center and foamy cytoplasm at the periphery. So this is also a two-tone giant cell. It's just cut at a weird angle. So apart from that, the intervening stroma shows these bland monomorphic looking cells with abundant cytoplasm. Those are histiocytes, and some scattered lymphocytes, plasma cells, and occasional eosinophils were also seen. So these are the key microscopic findings. There's a diffuse dermal infiltrate showing sheets of histiocytes with bland nuclei and two-tone type of giant cells. Variable amounts of lipid-rich histiocytes were there. The stroma shows lymphocytes, plasma cells, and eosinophils, and some fibrosis. There are no granulomas and no fungal elements were noted. So the final diagnosis we arrived at was juvenile xanthogranuloma. It's also known as solitary xanthogranuloma. This is the most common non-Langerhans cell histiocytosis, and it's commonly seen in children and infants. Sometimes it's seen in adults. 15 to 30% it can be seen in adults. Clinically, this presents as a solitary red-brown yellowish papular nodule, mostly in the head and neck region. It's a cutaneous lesion, but there can be extracutaneous sites as well. Ocular xanthogranulomas are also there. These must be referred to an ophthalmologist because it's common in kids younger than 2, and the complications are glaucoma and hyphema. That is why these have to be referred immediately. So the histology in these cases, earlier lesions, they'll have these sheets of monomorphic histiocytes with abundant eosinophilic cytoplasm. Older lesions will then progress to showing histiocytes which have a xanthomatous appearance, so more foamy appearance, and scattered lymphocytes and neutrophils can be seen. Long-standing lesions, they'll show interstitial fibrosis and proliferating fibroblasts. So you may not see these foamy histiocytes in all cases. And another variant is a spindle cell xanthogranuloma. These are composed of spindle-shaped histiocytes arranged in storiform pattern. And you can also see multinucleate two-tone giant cells and other mononuclear cells, which can be xanthomatous, oncocytic, vacuolated, and scalloped. So the IHC markers that will be positive, histiocyte markers will be positive, like CD68, CD163, factor 13A, and vimentin and factor 13A positive. It's also vimentin positive. They will be negative for CD1A and CD34. which will be CD1A will be positive in Langerhans cell histiocytosis. So the treatment for these cases, surgical excision can be performed. In ophthalmic xanthogranulomas, you can give topical, intralesional, or subconjunctival corticosteroids. And in cases where it cannot be resected completely, chemotherapy and radiotherapy options are also available. So the differentials that were provided, like in chalazion, we'll see granulomatous inflammation around these clear lipidized spaces, and it will be along with multinucleated giant cells, and there will be abundant plasma cells in that. In this case, plasma cells were less. Xanthoma, again, there'll be abundant foamy histiocytes, and usually associated with hypercholesterolemia. And xanthoma in the eyelid, it's called xanthilesma. But these giant cells and these foamy histiocytes are characteristic of xanthogranuloma. Langerhans cell histiocytosis, here the histiocytes have a different morphology. They'll have a reniform nuclei and grooving, and well-formed totem giant cells are uncommon. Other close differentials are reticulohistiocytomas. Here you'll have an irregular admixture of oncocytic mononuclear histiocytes, but here the multinucleated giant cells will have a ground glass appearance, and they will be Vimentin negative. So this is just a slide for the first years to differentiate and look at the types of giant cells that are there. So giant cells can be physiological or pathological. Physiological, these are some examples. So you can see megakaryocyte in the bone marrow. It will have a multilobulated nucleus and abundant cytoplasm. Osteoclasts, they'll have multiple nuclei and ruffled cytoplasmic borders. And also syncytial trophoblasts are an example of physiological giants. Pathologically, we can see Langerhans type of giant cells which have a horseshoe-shaped pattern, or they can be on either ends of the cell. Other examples of foreign body giant cells, two-tone giant cells like we saw, and tumor giant cells. Thank you. Does anybody have any questions?
Okay, so let's quickly move on to case number 2. Dr. Nivedita, are you there? Dr. Nivedita?
I'm there, ma'am.
Yeah, can you please share your PPT?
Yes, ma'am. Is it visible now, ma'am?
Yes, it's visible. Can you move on to the second slide? Let's see if it's moving.
Second slide.
Yes, please continue.
Good afternoon. This is Dr. Nivedita, first year postgraduate from Sri Atal Bihari Vajpayee Medical College and Research Institute. The case allotted to us was case 2. It was a case of a 23-year-old female with a lesion on the back with a diagnosis of query abscess. On a low scanner view, we were seeing 4 tissue fragments which showed skin with epidermis and dermis. The epidermis was unremarkable, and the superficial and deep dermis showed a diffuse inflammatory infiltrate which composed of lymphoplasmocytic infiltrate and also histiocytic aggregates as shown in the inlet, and also seen where collagen fibers were dividing the lymphoplasmocytic infiltrate into lobules as seen in figure C, and D is showing emperipolysis. We also noticed aggregates of polygonal histiocytes as shown in figure E, and it is also seen that the infiltrate was infiltrating into the subcutaneous tissue as seen in figure F. To summarize, there was a diffuse inflammatory infiltrate which was composed of lymphocytes, plasma cells, neutrophils, and also few eosinophils. The collagen fibers were dividing the lesions into multiple lobules. Also seen were aggregates of polygonal histiocytic cells along with emperipolysis, and the inflammatory infiltrates were extending up to the subcutaneous tissue. Based on the above findings, the probable diagnosis is a cutaneous Rosai-Dorfman disease, with the differential diagnosis being inflammatory pseudotumor, hemophagocytic syndrome, Langerhans cells histiocytosis, reticulohistiocytoma cutis, eruptive xanthoma, malignant histiocytosis, and Hodgkin's lymphoma. Thank you.
Very good, Dr. Nivedita. You can stop sharing your screen now.
Okay, thank you.
Can you see my presentation, Dr. Nivedita?
Yes, not yet. No. There's no. Yeah, now we can see.
Can you see? Okay. In case you can't see, just let me know. Okay.
Yes. Okay.
Okay, so with this history, so we got it as a query abscess. So initially we got a slide for review, and then after that the clinician here also performed a biopsy from the lesion over the back. And on discussing with the clinician, we elicited that this girl had multiple skin lesions all over the body in the form of pustules and papules over a period of 1 year. So the DDs that we received were cutaneous Rosai-Dorfman. As such, whatever you have told us, we've received all of those DDs in us. So one of it was an inflammatory pseudotumor, malignant histiocytosis, HLH, reticulohistiocytoma cutis, and Hodgkin's lymphoma. So I won't delve into the details of the microscopy because you've done a very good job at explaining it. But this is just a low power view wherein you can see the epidermis, the dermis, and the subcutaneous tissue. There was a neutrophilic inflammatory infiltrate with crusting, which was also seen on the epidermis. So this picture here depicts emperipolysis. This is a 20x view. Here you can see a germinal center formation as well. A higher power view of the same as you showed us. Dr. Nivedita, can you just tell me what all cells you're seeing in this emperipolysis that you described? Quickly.
We could see neutrophils, RBCs, and lymphocytes.
Anything else? Okay. Were they intact?
They were intact.
Okay. Why did I ask you if they're intact?
To differentiate
it from? What is it? Okay. So basically, I just want you to differentiate between emperipolysis and phagocytosis. Emperipolysis, they say, is the first step in NK cell mediated cell death. So that's where you see an intact cell. Most commonly involved are histiocytes, megakaryocytes, and rarely RS cells. As we know, emperipolysis is synonymous with RDD. However, in phagocytosis, it's mediated by the lysosomal enzymes. Commonly in the lymph node, if you see, you'll see tingible body macrophages, hemophagocytosis, and it can be associated with mycobacterial etiologies. This is just a picture depicting the same. The emperipolysis is from our case. The phagocytosis is an image I've taken from Silverberg's. If you can see, they're all like karyorectic debris. They're not intact cells. Can you tell me what you're seeing? We went ahead with IHC. So can you tell me what we're seeing on S100?
Positivity, no?
You want me to go to a higher power?
Positivity. Positive.
What type of positivity are we seeing?
Diffuse
Is it
positivity.
Okay, fine. So we had an S100 which was positive. If you can see here, this is cytoplasm. These are all of the cells which have engulfed. These are the histiocytes which are showing positivity here. This was CD68 which we went ahead and did, which is again positive in our case. These are all of the histiocytes, which is again cytoplasmic in nature. So we did a CD1A as well, and this was negative. So following all of this IHC, can you tell me why we did a CD1A? To differentiate it from what?
Yes,
do you want to tell me, or shall we go ahead?
To differentiate it from LCH.
Okay, very good. Excellent. Very good. So actually, I will not delve into each of these differential diagnoses that we've received because HLH, reticulohistiocytoma cutis were already discussed by Dr. Varsha. And in an inflammatory pseudotumor, what will happen is that you will have a little more of a myofibroblastic spindle cell proliferation as well. And this will be S100 negative. S100 was positive in our case. In malignant histiocytosis, you will have markedly pleomorphic cells, which was not seen in our case again. And in Hodgkin's lymphoma, you'll see the classic RS. We know that this is called Rosai-Dorfman, but can you tell me why there are 3 people here? It's called RDD. So is it Rosai-Dorfman disease or is there someone else? Do you know anything about the history, Dr. Nivedita?
No, ma'am.
Okay, fine. So this person here, the first person here, his name is Destombus. Okay, he was the first person to describe it in 1965. He was a French pathologist. So actually,
Dr.
RD.
There's no
slide is
PPT
being
is not.
From where isn't it visible?
From the history part.
Is my diagnosis visible?
No, ma'am.
No, nothing yet.
Now?
Please
Okay,
share
just give
again.
me a second. I'll share again, yes. Can you see it now, Dr. Nivedita?
No, ma'am. No, ma'am.
No, ma'am. Put it on
Now
slideshow
it's
mode. They're able to see it.
Now?
Yeah,
Is it on
I
slide
know.
share?
Diagnosis
Yes,
mode.
ma'am.
Okay. Okay, visible now?
Yes, ma'am.
Okay. So these are the three people. The first person here is Destombus. He was a French pathologist, as I told you. So it's called Rosai-Dorfman Destombus disease, first described in 1965, and then again in 1969 by Juan Rosai and Ronald Dorfman, who are credited with this disease. So the most common sites of extranodal involvement are the skin and CNS, more frequently seen in young adults, and the cutaneous form is extremely common among Asian women. So extremely, when I say the word extremely, I mean to say that among the Asian women, cutaneous form is common, although cutaneous RDD is relatively a rare disease. However, the definite etiology is not clear. Okay, so there are some associated diseases with this. We have some inherited conditions such as familial histiocytosis, which predisposes patients to RDD. Then we have neoplasia associated. Either it can be an Hodgkin's or an NHL. So if we have to say neoplasia associated RDD, more than 10% of the tissue needs to be involved by RDD. Just focal areas of emperipolysis are not a criteria to call it neoplasia associated RDD. Then we have immune related RDD, and that can be seen in SLE. Idiopathic causes also are there, and IgG4 related RDD. So in terms of IgG4 related RDD, the most common things that we need to look at are for obliterative phlebitis, storiform fibrosis, which is more common in IgG4 related disease, lesser commonly seen in RDD. Those are the only two features that can be noted as of now. The IHC, we have some positive and negative markers for RDD. In that, we have CD68, S100, CD163, and cyclin D1, which are positive. And under the negative markers, we have CD1A, Langerin, and BRAF V600E. This is mainly to differentiate Erdheim-Chester disease, and CD1A is to differentiate from LCH. These are my references, and I would like to acknowledge the departments of histopathology and dermatology at Manipal Hospital. Thank you. Case number 8.
Dr.
Okay,
Sabna,
now
are
do
you
we?
ready to
Can we?
share?
Yes.
Dr. Sabna, kindly unmute.
Sir, can you hear me?
Yes,
Yes.
please share a screen.
Yes, sir. Sir, is it visible?
Yeah, please start.
So myself, Dr. Shapna from AG Institute of Medical Science, Mangalore. My case number 8. The patient presented with a 23-year-old female patient came with the complaints of nephrotic range of proteinuria, low complement level, and normal renal function test. History of hair loss and joint pain were there. So we have received biopsy from kidney. So section studied from renal biopsy shows linear course containing glomeruli and tubules. The glomeruli shows linear course showing glomeruli and tubules. Glomeruli show mesangial cell proliferation and mesangial matrix expansion. There is mesangial cell proliferation and mesangial matrix expansion. Areas of fibrinoid necrosis and cells with pycnotic nuclei noted, and a few hematoxylin bodies also noted. also noted several valves, that is subendothelial deposits and intraluminal hyaline deposits, and focal glomerulonephritis characterized by segmental necrosis and lymphocytic infiltration and adhesion to the Bowman's capsule noted, and thickened capillary walls also noted. So the differential diagnoses were: first one, lupus nephritis, class 4, then IgA nephropathy, acute post-infectious glomerulonephritis. By analyzing the case details, that is, most common age group for lupus nephritis is 20 to 30 years. That is, female patients are more common for lupus nephritis, and nephrotic range proteinuria, low complement levels, all these favor the diagnosis of lupus nephritis. Features are glomeruli showing mesangial cell proliferation and mesangial matrix expansion, wire loops are showing, that is, subendothelial deposits and intraluminal hyaline thrombi that favor the diagnosis of class 4 lupus nephritis. Then next differential diagnosis, IgA nephropathy. IgA nephropathy also most common age group 20 to 30 years, but in IgA nephropathy males are more common than female, and nephrotic syndrome, associated nephrotic syndrome seen in IgA nephropathy, and hematuria is one of the characteristic feature in IgA nephropathy that is not there in our history. Other microscopic features like mesangial hypercellularity, that is more than or equal to 4 cells per mesangial space, and widening of mesangial matrix are the features of IgA nephropathy. Endocapillary hypercellularity, focal segmental glomerulosclerosis, tubular atrophy, interstitial fibrosis, and crescent showing more than or equal to 2 layers of parental epithelial cells are the features of IgA nephropathy. Then next differential diagnosis, acute post-infectious glomerulonephritis. Features are of acute post-infectious glomerulonephritis are proteinuria, hypertension, impaired renal function, hematuria, and edema. Low complement level supports the diagnosis of acute post-infectious glomerulonephritis. In acute post-infectious glomerulonephritis also, there is diffuse thickening of glomeruli, segmentally or globally enlarged, and with the endocapillary and mesangial hypercellularity. Neutrophilic and later mononuclear infiltration can also be seen in acute post-infectious glomerulonephritis. By analyzing the clinical history and the microscopic features, the diagnosis supports the lupus nephritis class 4. Thank you.
Thank you, Dr. Sabna, for the wonderful presentation. Now I'll be sharing my presentation. I think you've rightly pointed out. So a pathologist working in isolation here won't help come to a final conclusion. We have to include the clinical history here of an autoimmune disease, which is given as a in the form of history of hair loss and joint pains, and plus this age group. Autoimmune disease is the first possibility, and the most common of them is lupus, which will present as lupus nephritis in the current case. So we received various responses. Most of the responses were lupus nephritis. Somebody said it's MPGN pattern. Some people said renal amyloidosis and IgG4 related tubulointerstitial nephritis also. FSGS perihilar was also included. I won't go into the details of all these things, but I would just say that renal amyloidosis, IgG4 related tubulointerstitial, the people who vouched for them, please go back and look at your slides again, because you will be able to make out that it's a proliferative glomerulonephritis. There is a lot of endocapillary hypercellularity, mesangial hypercellularity, and these amyloidosis and IgG4 won't really present like that. So before going on to the case per se, let me take you through how a normal glomerulus looks so that you are familiar with the zones you have to evaluate in a glomerulus. You can see that these are the endocapillary, So the glomerulus has mesangial cells, the endocapillary cells, and the podocytes. These podocytes have numerous food processes, and the zone between the food processes of the podocytes and the endothelium, it forms the GBM filtration barrier through which all the proteins get leaked out if anything happens to this filtration barriers. So this is the ultrastructure of a glomerulus, wherein you can see the big yellow cell which is lining the capillary outside is the podocyte, is the parietal epithelial cell. The blue color small undulating processes, they are actually food processes of the podocyte. Then the orange one is the endothelial cell. The pink one between the endothelial cell and the podocyte is the capillary basement membrane, and the green ones are the mesangial cells. So basically, we evaluate a glomerulus in terms of mesangial cellularity, in terms of endocapillary cellularity. We have to look at the capillary basement membranes carefully. The podocytes and the podocytes food processes are not really appreciable on light microscopy. So to evaluate for a podocytopathy, you have to go to EM evaluation to delineate food process effacement. So coming on to the case, we had glomeruli, which are showing a lot of proliferation here. If you can make out here, the glomerular capillary lumina are completely obliterated and they're filled up with cells. So what are these cells? These cells are basically endocapillary cells, mesangial cells. They could be lymphocytes admixed and histiocytes. If you look at this compartment, this is actually the mesangial cell area. So this is actually showing this area is actually of a mesangial hypercellularity. And if you look at this compartment, this is actually proliferation of parietal epithelial cells, which is forming a crescent. So more than 2 cell layer thickness of parietal epithelial cell occupying 10% or more of the Bowman's capsule is qualifies as a crescent. And what are these red things? Dr. Sabna, what are these red things? You pointed out these. These very eosinophilic hyaline deposits.
Hyaline deposits.
Yes. So these are hyaline deposits or the subendothelial deposits, which actually cover the entire loop of the capillary. And that is why it is called as wire loop lesions, because they look like a wire loop. So again, you can see that there is endocapillary hypercellularity. These are wire loop lesions. And there is a lot of mesangial hypercellularity. All the gloms are showing these features. Let me take you to these are the areas of interstitial inflammation, which we could make out on a slide. Let me take you to the special stains. This is the PS stain. Now, a PS stain helps us, read the GBM more carefully and in more detail. So you can see here, these are nice wire loop lesions, which are actually, highlighted by PS. And these are the hyaline thrombi, which are within the capillary tufts. So these hyaline thrombi are very important because, you have to differentiate them from fibrin thrombi. These hyaline thrombi are usually very glassy and very eosinophilic, versus the fibrin thrombi, which are very granular in appearance, and they stain lightly for PS, not so dark. So next we come to empty stain. Empty stain is a very, very good stain, I would say, because if you don't have IF, sometimes it really helps you delineate where your immune deposits are. So empty stain will actually show red color wherever these immune deposits are, as you can see in this image. So these wire loop lesions are actually highlighted on empty stains, which are showing fascinophilia in these deposits. So again, a picture of empty stain, just to show that even subtle subendothelial deposits can be made out on empty stain if the stain is done well. Also, in routine practice, we do a PSM or a GMS stain, that is the silver stain. And it is very important to evaluate this as well in detail, especially in lupus cases, because class 5 lupus nephritis, as you all know, is a membranous lupus nephritis, and it can coexist with proliferative lupus nephritis, that is class 3 and 4. So class 3 plus 5 can happen, class 4 plus 5 can happen. So you really need to go onto your oil immersion and look for these spikes and pinholes many a times. So in this case, the pattern of injury we are looking at is diffuse proliferative glomerulonephritis, that is mesangial hypercellularity, endocapillary hypercellularity, via loop lesions, occasional cellular crescents are there, and interstitial inflammation is there. So what are the differentials based on this picture? As you rightly pointed out, lupus nephritis, infection-related glomerulonephritis, and IgA nephropathy. Sometimes we do see membranoproliferative glomerulonephritis pattern, but not in this case. The people who have made the diagnosis of MPGN, I've just included this for their information, the MPGN, but this case per se doesn't show an MPGN pattern. I'll show you how an MPGN looks like later. So what will help us delineate or come to a conclusion in any case? So if you work in isolation, just looking at your LM findings and just looking at your IF findings, you don't know about serology, you don't know about clinical history, sorry, you will not be able to come to a conclusion. You need to call your doctor, you need to talk to them, you need to understand what the patient is going through, what are the symptoms they have, and the serological correlation, especially ANA, anti-double stranded DNA, and the entire ANA panel is very, very crucial in these cases. So in our case, we got a full house deposit. We generally do IgG, AM, C3, C1q. And C1q plays a very important role in lupus cases because it tells us that the classical complement pathway is activated. So when is the classical complement? Basically, these immune cells which will be formed in the bloodstream, they'll get deposited according to their charge within the glomeruli, and then they will activate this complement pathway, resulting in hypocomplementemia, and these complexes will be deposited along the GBM everywhere, and the neutrophils and the inflammatory cells which come along with them, they will release some chemokines, cytotoxins and everything, and they will incite more inflammation and so on. So this is how a final diagnosis goes. I showed you that this patient had a full house pattern. She has an autoimmune history. She's a young female, and serology was also positive. So the primary diagnosis given in this case was lupus nephritis. You have to tell what class it is according to the ISN RPS classification, which divides lupus nephritis into 6 classes. Then you have to tell the pattern of injury. The pattern of injury, namely in this case I have mentioned in the slide. Then you have to mention about the activity index, the chronicity index, according to the modified NIH lupus nephritis activity and chronicity scoring systems. And sometimes you may get some vascular changes which are associated with lupus, or some immune fluorescence deposits which are extraglomerular in nature, like tubulointerstitial deposits, vascular deposits. So just be careful when you are screening these cases under IF. So just to take you through, these are the various classes of lupus nephritis according to the ISN RPS class. So you can go through them in detail. I'll just tell you the bigger things, that class 1 will look normal on light microscopy, but you can have mesangial deposits there. Class 2, you will see these mesangial hypercellularity areas, but there will be no proliferation. There will be no endocapillary proliferation or other elements of activity like via loop lesions, neutrophilic infiltration, and other things which we see in class 3 and 4. So in class 3 or 4, basically is divided on the basis of how many glomeruli are involved. If it is less than 50% gloms involved, it will be class 3. If it is more than 50%, it will go into class 4. And if you have a membranous kind of pattern, you are seeing these intramembranous deposits, you will label them as class 5. So class 5, as I previously also told you, it can coexist with class 3 and 4, wherein you will have the proliferation, all the signs of activity involving less than or more than 50% gloms, plus you will have these intramembranous deposits. So this is the ISN RPS classification for lupus nephritis. There are 6 classes. You can go through them in detail. I've just touched on them. Then this is the modified NIH lupus nephritis activity and chronicity scoring system. Basically, you have to deal with all these 6 parameters, as Dr. Sabna has also told: endocapillary hypercellularity, neutrophils, fibrinoid necrosis, hyaline deposits, cellular fibrocellular crescents, interstitial inflammation, and chronicity based on total glomerulosclerosis, fibrous crescents, tubular atrophy, interstitial fibrosis, and so on. So Dr. Sabna had given differentials of IRGN and IgA nephropathy. I would be just showing you the basic pictures, how it looks like. So IRGN will have quite a bit of neutrophilic exudation in the glomeruli, and generally wire loop lesions do not happen in IRGN, but we have seen cases wherein it can happen. It's not a hard and fast rule. Then this is the silver stain showing the same thing. And you will see on IF there is a starry sky appearance on C3, and C3 might be accompanied by IgG or may not be also. I mean, it's not a hard and fast that you need to see IgG in infection related. But the clinical history is the most important. I can't emphasize more on clinical history. Talk to your doctor. Is there fever? Is there hypocomplementemia? Is there an acute presentation? How is the serology, and so on? Next is MPGN pattern. MPGN pattern, the gloms will suddenly start looking like flowers. You can see these nice petals of gloms, and they'll all be filled up. You will not be able to see these patent capillary lumina. Plus, as the name suggests, membranoproliferative. Double contouring of these membranes will happen in membranoproliferative. And this is the IF thing, IF image. You can see these kind of linear and granular deposits which are deposited along the GBM outside, and there are some mesangial dots as well here and there. So this is MPGN pattern. Okay, in this case per se, you didn't have MPGN pattern. It was a diffuse proliferative glomerulonephritis. This is IgA nephropathy. So IgA nephropathy is basically, you will see mesangial proliferation. You can see these crescents, which is extracapillary proliferation. You can see endocapillary proliferation. The most important thing, IgA in mesangium, it actually, when you look at the low part, it'll look like a tree, branching tree here and there, and these capillaries will be completely absent. This is a very important point, mesangial IgA deposits for IgA nephropathy. If you see IgA along the capillaries and not the mesangium, think of secondary IgA deposits, not a primary IgA nephropathy. So this is my take-home slide. The differentials in this case were namely lupus, MPGN, infection-related IgA nephropathy. Can't emphasize enough on serological study, biochemistry parameters, what are the feedbacks of the clinician, how has the patient presented, is it a nephrotic syndrome, is it a nephritic syndrome, and is there any focus of infection, and IF, in conjunction with everything, immunofluorescence. Thank you so much. Any questions, please?
So we've come to the end of our presentations. If there are any questions.
Dr. Archana, we should close the meeting. I don't think there are any.
Okay. Okay, sir. Thank you so much. I would like to request Dr. Vidya ma'am to just deliver the closing remarks before we end the meeting.
Yeah, thank you to all the PGs who have made this effort of seeing the slides and going through slides very well, and many of them have actually made the diagnosis. It is nice to get the differential diagnosis, and maybe we could have got it a little earlier as well. And I would want to thank Dr. Aditya again for all the efforts that he has taken to organize this session. My special thanks to my colleagues in the department, especially Dr. Archana, who has been working on this for the last 15 days or so, and my entire team of doctors for taking time out of their busy schedule and making their time for this. And of course, my technicians who have done all the stains, immunostains, everything for us. So thank you once again. Thank you, KCIAPM.
Thank you, ma'am. Hello all, we'll be back with the next slide seminar in April, on April 20th from RV Metropolis, Bangalore. Until then, stay tuned for the slides. Thank you all for joining us today. We shall be closing the